Association of Minimal Access and Digital Surgeons. So it will be a great event, definitely. My surgical colleagues and the trainees in surgical field will benefit out of this surely. Best wishes, and hope you will enjoy this program. Thank you very much. Thanks.
And I would like to invite Prof. Maharagama also to have some few words. He has already come today morning, straight away from Dubai.
Thank you, Niroshan. Good morning, the President of the Sri Lanka College of Oncologists, Dr. Jayakumaran, and the organizers, Dr. Niroshan Atulagama, and senior oncosurgeons, Dr. Anuruddha Thoracolaparoscopic and Dr. Manatunga. Thank you very much for organizing this. Actually, it is, as Niroshan said, minimal access surgery is going to be the future. So we have identified that all our trainees should be well trained on this, and maybe in next few years we will get robotic surgery also into the country. So that's why we have named our association as Minimal Access and Digital Surgeons. So we have to be in par with the rest of the world, otherwise we will be lagging behind. So we have enough local resources now to train our trainees. So those days, maybe 5-6 years ago, these surgeries were done by foreign surgeons. Now we all are happy that we are in the position of doing these surgeries by our surgeons, and our trainees are in better position to train, get themselves trained. So our objective is to do minimal access surgery, ensuring the patient safety. So those are the main important things that we have to keep in mind. I don't take much time. Let me congratulate the College of Oncologists and the Association of Surgical Oncologists in Sri Lanka. I think the patients are already been anesthetized, so we will go ahead with the program. Thank you very much.
Thank you, sir. So first I would like to invite Dr. Anuruddha Thoracolaparoscopic. So just to give a brief discussion about port placement and the basic steps. I think slides will be displayed here.
First of all, let's acknowledge the pioneer of advanced laparoscopic surgery in Sri Lanka, Professor Dalgan. He was the first one who did minimally invasive laparoscopic surgery. Actually, he used a semi-prone position. He had his own reasons for that. I had the good fortune to be associated with his father, a pious gentleman who helped our cancer hospital a lot. Now, before we start, one important thing I have to tell you is that if you haven't done a thoracotomy, then I don't think you should be doing thoracotomy. Because thoracotomy is a very, very simple procedure. It is a 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 very simple procedure. It is
think so we can send Dr. Amrut Thevarapirum to theater so that he can get prepared. Wait a minute, just 1 minute. So we have a token of appreciation now because our bosses are going to leave. Before that, I think we'll present that. We'll ask Dr. Kokulan, he's our SR. Yeah, Kokulan. So you can present the case. Yeah. Dr. Pasagaram.
Good morning, everyone. So we got a patient, a 55-year-old ASA1, ECOG 0, a Mason, father of 1 from Kurunegale, presented to a local hospital with a history of progressively worsening dysphagia. Initially dysphagia for solids and later progressed to liquids as well, but he does not have any problem with initiation of swallowing. Despite of having a good appetite, he has lost significant weight subjectively. He is a smoker with 0.5 pack years and an alcohol consumer on a regular basis. There is no past history of upper GI instrumentation, family history of tuberculosis, or corrosive ingestions, or any past or non-contact history of tuberculosis or family history. There are no features suggestive of local infiltration such as hiccups, hoarseness of voice, recurrent chest infections, or interscapular pain, and there are no features suggestive of a distant metastasis such as early morning headache, nausea, vomiting, pleuritic chest pain, loss of appetite, or lower back pain. On examination, he is a thin-built patient with a BMI of 18.4. He is not pale or icteric. There is no vertigo knot, no ankle edema. His abdominal examination was unremarkable. And the chest examination was also normal. So we investigate the patient, focusing on confirm his diagnosis, assess the extent of the disease, as well as assess his fitness for surgery. We have done the upper GI endoscopy, which revealed an esophageal growth at 30 centimeter. It was totally occluding the lumen, so we could not negotiate through, so we were not able to assess the rest of the upper GI. And the biopsy from the lesion revealed to be a moderate differentiated squamous cell carcinoma. And we have done the CT, which showed a short segment malignant looking stricture involving 4 centimeter from T7 to T9. And the rest of the assessments, his laboratory investigations all were within normal range, and 2D echo lung functions were also normal. Thank you.
Yeah, so we basically heard about the patient. So what we will do is we will just pose some questions to our trainees and also all to the audience. And of course, there are some experts in the audience, so that you can get some feedbacks. And of course, we have prepared some slides so that we can actually back our evidence with those information. So now, as you heard, now the first thing is if it is a dysphagia patient, of course, the first thing that we would do is do an upper GI endoscopy. So what do you think that you should be recording in an upper GI endoscopy? Any volunteers that you want to answer?
So we just want to know whether there is an obvious lesion, and if there is a lesion, we just want to know the site of the lesion, and whether the scope is negotiable or not. And so if we can negotiate the tumor, and then of course we can go into the stomach, and before that we just want to know the GOG involved or not, and if the GOG is involved, what is the Siebert classification of the tumor, and then the status of the stomach is necessary to be observed, because it will be the future conduit. And once we are coming back, we just want to know we just want to take at least 6 to 8 biopsies to improve our sensitivity of to improve the sensitivity of the biopsy, and those are the main things that we should look into in our upper GI endoscopy.
Just a minute, Prof. Maharagama is going to leave. Yeah, no, there's a token of appreciation for Dr. Chaturanga. We'll ask him to present that. He's a candy guy, so he would appreciate this. Sorry, I was disrupted with this thing. So, thank you very much. That was a good description. But just one question. Now, say you said that you need to look at the location. So, how do you identify the location? What do you mean by the location?
So we have to see the characteristics of a tumor. So the proximal margin and the distal margin. And if there is any, for example, if it is like a gastroesophageal junctional tumor, so there may be an association of mucosal changes, just like Barrett's-like changes. And so for that we can use. I'm Vibhuti, Dr. Vibhuti.
So, my question is like, how do you locate the tumor within the esophagus? I mean,
so we just want to know whether it's a proximal, distal, or toward the gastroesophageal junction. So if it is whether it is from the upper cricopharyngeus, so we have to locate it from the cricopharyngeus, whether it is within the 6 centimeters of the cricopharyngeus. So if it is within 6 centimeters, it is likely that it is upper esophageal cancer. And then you have to assess the gastroesophageal junction as well. So in a short stretch of patients, so the gastroesophageal junction may be a bit shorter. So in that case, the upper third, middle third, and the lower third will be deferred. So in that sense, the middle third and the lower third gastroesophageal junctional tumors will be different to where the GOJ junction is actually in the 40 centimeters mark.
Exactly. So, as Vimurthy said, now, you just cannot go with the length because, 35 centimeters in a long stature patient would mean actually it's a low esophageal cancer. But it was short stature patient, 35 centimeters means just maybe a GOJ junction tumor. So, just length itself is not going to give you any interpretation. So, if you are actually saying what is important is we want to locate whether the tumor is actually in the cervical esophagus, thoracic, or intra-abdomen, right? So, because why do we want to know that? Because the management is going to change. So, it's not only the length, but there are, certain landmarks, the sternal notch, azygous vein, inferior pulmonary vein. These are some landmarks on the CT scan which might guide you there to find the location of the tumor, right? Okay, so now he was talking about Sievert's classification about GOJ tumors, and of course I am pretty much sure everybody knows about the Sievert's classification. But then if you go to the next slide, now the question is like, when you have the true junction, anything above the junction we know is a esophageal cancer. But problem is when the cancer happens below that line and closer to that line, right? So what can you say? This B, and what about B? B is a esophageal cancer or a gastric cancer? Any guesses?
It's a marginal case. It should be classified as GOJ tumor. So looks like it's epicenter is in the stomach. So I think it's a gastric cancer. It's again gastric.
epicenter should be within 2 centimeters. Now see, this one epicenter is within 2 centimeters, but its junction is not involved, right? Here junction is involved, but epicenter is more than 2 centimeters. So that's why it falls into a gastric cancer. So the management would be like a gastric cancer, right? So, and this case is pretty much like a esophageal cancer, right? So that's why, it's very important when you're recording, because management of gastric cancer and esophageal cancer is completely different, right? Okay, so now the other question is common scenario is, now that's why it's very important to look at the lower border of the tube, the full extent. You need to know where the epicenter is. Now, commonly in day-to-day practice, what happens is, like in our patient, you cannot pass beyond the lesion, and we don't know what is the extent, lower extent. Especially it's a problem when it's a GOJ tumor. Yeah.
How to find the epicenter?
Huh?
How to find the
Yeah,
epicenter?
exactly. So that's the thing. So you have to look at the full extent of the lesion, and it's a rough guide. It's a rough guide. You just get it's a rough guide to look at the center of the lesion. There is no exact way. You just look at the whole lesion, and then you roughly think this is the center of the lesion. This is in all cases, or?
Yeah, even GOJ also, radiologist might give an idea. So you have to have a collective idea, endoscopically as well radiological, to see where is the epicenter.
So how do you tackle, now in the case like, when there's a full obstruction. Now one thing is, there are two problems in that. One thing is finding the epicenter. Second one is, these patients will need some nutritional rehabilitation. So those are the two problems that we are going to face when you're going for the management. So how do you tackle? Of course, as I think Buddhika said, I think CT is one way out, finding the epicenter. Any other thoughts? Because I think, the problem is like, if you can pass a NG tube down, then of course you can distend the stomach with oral contrast. Then of course the mucosa will expand, and then of course you can delineate the cancer very well. But what about tackling the dysphagia?
Actually, if it is an obstructing tube, mostly it belongs to esophagus rather than a gastric tube. If it is gastric tumor, very unlikely it get obstructed. So if it is really obstructing tumor, I think we have to take it as a esophageal, because once it get into the esophagus, the margins are 10 centimeters optimal margin. The problem is whether we can use the gastric sleeve to reconstruct, or
Yeah,
whether
exactly.
will it be adequate. And we have to get hold of imaging, maybe Bayesian, if he can fuse some study.
Yeah, there's another thing which I want to mention. So even though we think it's a GOJ tumor, so when you do the J maneuver, so you have to go for the mucosal changes. So so we always in our center where I work in the UK, so they take biopsies around 5 centimeters from the GOJ to see whether there's any significant dysplasia, because that is where you go to fire the stapler. So you get a positive margin in the stapler. Just the tumor is, macroscopically we see sometimes, exact growth is at maybe about 2 centimeters or 3 centimeters from GOJ. But, there can be a slight dysplastic changes when you go for the NBI weave. So you might see some changes. So that is a very tricky point where you might, get the margins positive at some point. So therefore, you have to always think just macroscopically what you see, plus put an NBI weave, also go and see whether there's a positive, dysplasia. There's a merging dysplasia from the tumor. That is very important.
That means during the surgery? During the surgery, or? Yeah. No, I don't know. I don't usually practice it. I don't know whether Chaturanga does it.
What we do is, if you have any suspicion, I think best thing is preoperatively or endoscopy, go for biopsies.
problem is actually now my problem is now this is pre-operatively we need to make this decision.
Exactly.
Right? It's not at the on the table, not after neoadjuvant. The neoadjuvant should be decided whether it's a esophageal or a gastric.
The lesson is, if you are the surgeon, whoever who has done the endoscopy, you do the endoscopy yourself. That is the lesson, because the documentation, we accept everybody's reports are correct. That is perfectly fine. Because you are going to make a decision on your patient. So always do endoscopy.
You don't have the confidence if you haven't done.
Yes, yes. So I personally do it only because of this reason. Because sometimes you get dysplasia. Everything you mention nicely, everything is true, but you don't want to get a positive margin.
Chaturanga, so what are you all doing in this sort of cases? Like there is complete obstruction, you cannot assess the distal extent. So how do you make that decision?
If you have a complete obstruction,
Yeah.
so then you have to, because that patient, that is an advanced tube. So patient needs neoadjuvant. So what you need to assess is, you can slightly dilate and put the scope in and go for.
Problem is when you cannot do that.
Yeah.
The other one, if you dilate, you make upstage.
Yeah, upstage, true. That is, there are concerns. But the thing is, you can't send a patient without seeing the proper stomach, because we don't know, before giving neoadjuvant, what the extent of the disease in the stomach itself. From GOJ, which extent it has gone down.
I think I agree with Karnataka, because when it is very stenotic lesion, you shouldn't try with the endoscope. You can dilate and pass and you can do the biopsy.
Yeah.
But then again, it will damage your future imaging as well.
Exactly, true.
And you must go with the CT scan and then assess. And I totally agree. Again, if it is completely obstructed, this is a very advanced case. And you have to go with the CT findings, and then the staging is very important. And definitely new. And if you pass the scope with strain and dilation, everything can be done. But future imaging will be changed because of the strain and the edema what you are doing, and as well as you can upgrade the tube as well.
Exactly. So that's the whole idea. I mean, like, in situations where you cannot actually pass the scope, you need to have a good radiologist, right? So you need to have a radiologist to differentiate whether it's actually more likely a esophageal or is a gastric cancer, right?
So other reason the duration, we always take some biopsies in that patient.
Yeah.
Anyway, do CT scan. After the CT scan, you might have to put a stent for this patient for feeding purposes.
Yeah.
So then when you are putting the stent, because you have to send for neoadjuvant, you have to put the stent and send for neoadjuvant.
Yeah. So that will be done after the imaging, right?
Yeah, after CT scan. So suppose you can't negotiate. So you take biopsies and come. You do the imaging, and then after the imaging, you go in and dilate, and then you put a stent across, because anyway you have to dilate at least a little bit to put a stent.
Yeah, exactly. So now that leads to another question.
Stenting in this situation or any other way of thing, because the problem with the stenting, again, if you dilate, you can rupture this venous. There's possibility to an upstage, so you are making more advanced. And the other problem, you can decide whether with the staging, anyway we are going to go for a surgery, or depending on the staging, and decide if it is anyway, if it is not operable, then we can go for stenting. But I'm asking question, stenting or any other treatment?
That's the thing now. I just want to lead that question. Now, that actually raises a very good question. Now, because sometimes some oncologists, they don't like if you have a stent. Because neoadjuvant planning, I don't know, some they raise a question, concern. I don't know whether that's a true concern or not.
The thing is, if you are planning for esophagectomy, it's better not to do a stent, right? So that will increase it reverse the prognosis, one thing. Other thing, for the definitive chemoradiotherapy, there will be no much problem with stent, right? The area where we are going to do radiotherapy will be a bit higher, but with the normal techniques, we can actually reduce the surrounding dose and maximize the tumor. So safety is not a problem for the radiotherapy, but for if you are going for esophageal, better not to do a stent, right? Better to use
There's no problem with radiotherapy plan.
no.
can't pass the scope.
Right.
So in that scenario, you can't
So
use.
dysphagia and biopsy, actually we can see the mucosal area with the endoscopic
What I told earlier was when you go to the stomach and we have a tumor reaching about 2 centimeters, right, from the GOJ. So we have to have adequate, because lesser coverage is the problem. That is where we fire the stapler across. So if there's any dysphagia, in the mucosa, so that obviously you can see with your NDR, because we have advanced, that is mucosal imaging. Mucosal imaging can be done with advanced endoscopy, and we can take biopsies from that. And in case if we have suspicion, just to see whether there is any dysplasia.
So I don't know what is the conclusion now. So now the question was, so this is Dr. Anish Krija, he is the president of surgical oncologists. The question was now, when you have a completely obstructing tumor, especially in the GOJ, one thing is how do you assess the distal extent of the tumor. Other one is how do you overcome the dysphagia. So all this time you were saying that CT scan is the only way out. Without dilatation, go for a CT scan with the proper imaging. Other than to access the distal extent.
I will tell you what we had recently. Now there are the problem is these 5
Pirusha, oncologist at Ratnapur.
Yeah. I can even without this, But no, I reduce now the current problem that we have is actually the limitation of the imaging actually. This is my long-standing experience, because the thing is, in which case, if you have to have a good imaging, the radiologist will have to spend hours on doing it. They will have to alter the factors and things like that. Recently we operated a patient who had a GOJ tumor, which was an advanced tumor, who has had the neoadjuvant chemotherapy, and the tumor has shrunken. No, that's what it was, and there was a GOJ area, and then we were planning to do there was no level 2, the subcarinal nodes were not enlarged, but we took them out. We did a transcarinal and completely dissected it. And the problem was, when we went in, we found there were tumor seedling on the wall of the stomach, which has actually not been picked up by the seedling inside, not outside. Even when we went in, we didn't see it. Now, if we had done on laparoscopy, we would have missed it totally. Because we were feeling with the hand, I said, no, it's about this size, no? About 1 rupee size, intramural deposits were there. So now by that time we have committed by doing the transactional part also. So now we had either we had to take the colon out, so then I had to skew the esophagus, skew the stomach and get a tube out. So what we did was, we opened from the medial view and then put the stapler touching with the hand, the touching put a stapler cut, so ultimately when he recovered, he had no problem. The stapler line was spirally around the constructed esophagus. So that kind of thing, even if you do an MBA, you can't hit it. Now, the thing is, MBA is a very good advance in endoscopic techniques to find the mucosal thing if you can see from mucosa. But sometimes the problem is these things can be intramural, and then of course you have to highly depend on the imaging. So, but then to get that type of imaging, the radiologists have to spend a lot of time, and we have to have specialized radiologists handle these things. Now, these are the issues that can happen.
So the one which should be picked up in a CT scan, isn't it, sir?
Yeah, it should be when you end up on NDT. And but the thing is, it has not been picked up. That's the issue. I mean, should be and being picking up are two different things. So this is the problem.
Basically, what Pirusha is saying that, so
to overcome the dysphagia part, what you should do is dilatation and maybe passing an NG tube.
Yeah.
Rather than going for a stenting.
Stenting them out after
radiological guided geninostom rather than dilatation. Because the concern is if dilatation, the rupture, it will make the difficult, especially tumor, upstage, and other part of it will be difficult to infuse the surgery. So, we don't have that option, the radiological inserted geninostom, more than
but that will affect your future surgery.
Radiological that's
feeding geninostom. So you want to
nasal tube.
Okay.
Or else can we go for, if it is like complete obstruction tumor, we know it's an advanced tumor, can't we go for sort of laparoscopy and assisted, and at that time we can see the distal extent externally if you want to see that one, but it is not good enough to see the distal extent. At the same time, for the feeding versus, if we can't put NG tube, we can go for the laparoscopy assisted feeding geninostom. What about that?
Yeah, but then, diagnostic laparoscopy might be at some point you will be able to you have to do a diagnostic laparoscopy if it's a GOJ tumor. At that time, of course, you can put a feeding geninostom, but that's true. That is also an option.
I am the image, and as Kanisha told, whatever the pre-op assessment, the intraoperative finding will change the course of the surgery.
Because if you put a feeding geninostomy, it's not going to totally affect your outcome or something. You can keep that feeding geninostomy and post-surgical feeding. There's nothing wrong in putting a feeding geninostomy. Either you can put a laparoscopic probe or whatever you're going to do, like geninostomy, and use it for subsequent purpose. But I don't think you should put stenting in these patients, because if you put a stenting, it becomes a huge problem. If you perforate or something, then your chances of doing a surgery will be low. If you are planning to do surgery, better not put a stent.
No, because the point is, now if she says that putting a stent in a difficult case is possible, first thing, because there are very difficult cases we can put a stent. But the point, what she mentioned is the one correct, which is, what she says is, there are problems in chemotherapy. So if the chemotherapy won't penetrate well when you put a stent, that is an acceptable problem. Because
I don't think there is issue like that. No.
Is there anything like that?
There is no problem with chemotherapy. With the chemotherapy, it can destroy the tube. When the tumor
shrinks.
Then can get destroyed. Other than there is no problem with chemotherapy.
If the patient is liquid
I need somebody who thinks it.
liquid solution, we don't need to do anything. Because all the higher centers with lot of numbers in I think they do a stent at the moment. Currently, I don't know about your center.
No, the main concern is that they are against the result of risk of perforation and upstaging. They are always trying not to do something with the tube. Because if it's a squamous cell, when you give fluid on some radiotherapy, the insurance is the oral. So they
No. That's what I'm telling. If the patient can take liquids, so this is called a total dysphagia. So we are talking about not an advanced tube. We are talking about a total dysphagic patient. So that is the only concern. But if the patient can tolerate liquids, they can stay on liquids and no stent, you can go for neonatal. With the radiotherapy, that will bring the tumor within first couple of days. Tumor will get enlarged, and after that, tumor will start shrinking. So we will be facing only problems for 2 weeks. So generally speaking.
You need some kind of infusion.
So what you need by nutrition is nutrition. That's why we have a ADD approach. We have a nutritionist. So we can get the nutritionist on board and you tell what is the calorie requirement, what is the protein requirement. Everything can be given in liquid form. So we have nutritionists to do that. So we don't necessarily give rice, we don't necessarily give kanji, because those are outdated things. There are many things which we can give at the moment to the patient. So why don't you go for the liquid nutrition and give me one? Yeah, immediate the patient is receiving liquid nutrition. So why not oral liquid nutrition? You have to
My question is when the patient has a total disease, even they have already liquids. Yeah. No, I don't know. What are your practice there when you were there?
Because what we say is, in this situation, they are very reluctant to do anything for the tube area. So the dilation and state, right? That's because of the soft state. So what they do, they go for alternative feeding like regularly inserted mesovaginal tube, right? Or sometimes they guide inserted. Or sometimes they must not. So that's one main point. What they say is they are reluctant.
So they will be doing open surgery. They will be doing an open surgery.
No, laparoscopic. Yes, there is staging and rupture is.
So staging will be affecting how you operate the patient.
Yeah.
And after that.
It won't affect. The reason is that is why it has to be done by a person who is going to operate. Right? So, if the tumor is 30 centimeters and if it is a squamous cell cancer, so you are going to do the anastomosis in the neck. So if it is a neck anastomosis, only problem what you face in the stent is making the stomach tube, one problem. Other thing is that proximal margin. Proximal margin will be affected only 2 centimeters. Always. When they put a stent, proximal 2 centimeters from the upper margin of the stent will be affected. So then you should not be putting a stent upper margin, it will be closer to 20 centimeters. That's the only sole point.
No perimeter fibrosis, no dissection, nothing like that.
Difficulties are there. I mean, there can be slight, but of course you can manage.
So this is a just part of being an expert. You can have divided type. But if you are training, of course, you can only have one. So then we move on to so now we are in the diagram. The next stage is being a stage. Then everybody say how are you going to do the stage?
And it is very early tumor, we can go ahead with the endoscopic ultrasound to characterize the T1 or T2 lesions. And also liver lesions and mediastinal nodes and free ascites also we can diagnose with the endoscopic ultrasound. Endoscopic ultrasound is best for T stage, and for metastasis, best is the PET-CT.
I totally agree with Dr. Andima. The EUS is basically mainly for the T1 and T2 tumors, because the delineation of T1 and T2 tumors within the T1A or the T1B also very important in managing whether we are going for the endoscopic dissection or whether we are going for the oesophagectomy. Another thing is whether we are going for the neoadjuvant treatment. Because we all know if it is more than T2, we have to go for the neoadjuvant. T1, T2, we can straight away go for the surgery. But other important thing about doing a US is that if there is lymph node, perilesional lymph nodes or periesophageal lymph nodes, we can go for the biopsy, FNAC, US assisted FNAC of these lymph nodes. And that will give us a sort of idea whether these lymph nodes are available. And of course, we have to go for the beyond T2 for the CT scans for the rest of the stage.
If I ask, I don't know, I don't have much experience on EUS, but how many EUS machines are functioning in government sector? I know NHSL one is functioning, but Kalubovila one I don't think is functioning. Candy is not working, I suppose. So we have only one functioning machine in Sri Lanka in the government sector. So that is the main limitation in clinic.
If there are lymph nodes, you don't worry.
Yes.
If you are doubtful case only, it has a
True.
So it's a selective.
Exactly. So that is one reason is the unavailability of the resources. So we are limited with that, even though the patients are indicated, but we don't have access in government sector. That is problem number one. The other thing is what is the scope diameter of EUS? It's more than the normal scope, right?
So 1.2 centimeter.
Oh yeah, 1.3. So if you can't pass the normal scope, of course you can't ever think about that. So that is the other problem that I think, with the EUS, even though it is, the literature says it is superior, but practically you have that limitation. The other question is that when you do a FNAC, as Buddhika told, you said, the marginal cases or CT in doubt lymph nodes. If that lymph node is located posterior to the tumor, what is going to happen? So you are going through the tumor to get the node FNAC. So is it going to affect the outcome? Can you understand my problem? No.
It won't affect. The reason is because we are going to take the whole thing out. We are going to leave.
No, I'm talking about the FNAC. You are falsely upstaging.
We are going through the tumor, but cells might say it's malignant, but we are not.
And on top of that, you are leaving tumor cells in the mediastinum. Isn't it, Chaturanga? Yeah. So that is the other issues. Of course, the staging-wise, as we.
No problem. But the problem is that our US reporting is bad generally. It's like very experienced. Those people, they can tell whether the lymph node is malignant with the US. You don't need necessarily you don't need a biopsy, right? Yeah. So you don't necessarily need a biopsy. If you have looking at the characteristic of the lymph node, you know this lymph node is malignant in this thing.
I think the major role of EUS, rather than detecting the lymph node, it can predict the possibilities of lymph node metastasis. So if the tumor, especially for the early tumors, if it is beyond the submucosa, the probability of getting the positive nodes, it goes up to 80%. So then we can plan for the radical surgery rather than a non-radical oesophagectomy. So that is the big use of EUS, rather than finding a lymph node and taking a biopsy.
So basically, EUS is generally considered as far superior imaging only in terms of lymph node dissection. And as Dr. Ranga said, you have few characteristics. Like if it is more than 1 centimeter, it is circular in shape, and if it is hypoechoic, that is more suggestive. Like 80% sensitivity that the lymph node is infiltrating. So another thing is like now the next option is, are we
do a PET scan, and PET scan is going to help in detecting lymph nodes, or what's the sensitivity when it comes to PET scan? Any idea? So usually we all do, I don't know, in your centers we all do PET scan routinely, or
no routine PETs. No routine PETs. If you have any suspicious area like adrenal or somewhere, so in addition to the CT finding, there's a place for PET to see whether there's a MET. But otherwise, we directly go for surgery without a PET scan. I don't know about.
Yeah, actually, I mean, there's something about PET scans. It applies for everything in PET. In Sri Lanka, of course, the PET scans, the available PET CT resolution is much lower than the standard CT. With the standard CT, the slices are 250 sort of thing. Whereas the PET CT, the resolution is much lower. So therefore, normally, if you missed by some lesion by PET CT, you can pick up by the normal CT. So generally, a normal CT should be done beforehand. CECT would give a uptake plus every, not only the thing. So our PET, of course, will be in Sri Lanka. The PET CT is anyway little issues, and also you can pick up inflammations and infection. All those will be picked up. So the PET CT for sure will upstage, really. Whereas a normal CT in that sense might be, I think, better at least in Sri Lanka. I don't know about the resolution of PET CTs and other things.
We'll undergo PET CT scan. So that was their
institution,
and also laparoscopy.
If they find a positive PET, will they avoid surgery?
Yes.
No, so they must be having a good resolution CT.
Yeah, it was 98% like GOJ tumor. You hardly will get a squamous cell cancer.
Yeah, because they must be having good PET CTs.
Yes.
So in our setup, the PET CT is different.
So then on the other hand, again another question, so, what about the sensitivity of PET scan in adrenal carcinoma? Obviously, squamous cell carcinomas would have better pickup rates, but adrenal carcinoma is signatory cell type. Of course, they will have a,
So they are doing the laparoscopy as well with PET CT. So all the patients will undergo diagnostic on this.
If it is T4A disease or somewhat advanced locally advanced disease and following irregular tumor radiation, the tumor probably has shrunken, but still radiologically from the normal CT it may be difficult to say the invasions. So is there a place for PET
assess the individual response.
Before surgery.
Yes.
But the staging laparoscopy will do before. Because you can mobilize the GOJ, lift the GOJ, that is one thing. Principally, whether it is T4B or T4A, just, when you do the staging laparoscopy. Yeah. Servus and peritoneum, yes. But the thing is, you before proceeding for your surgery, when you lift the left lobe up and mobilize, just lift the liver, GOJ there, so you know whether you are going to face a difficult surgery or not difficult surgery. Because you might just do this thing and you will see huge left gastric lymph node mass. So there are the things you pick up with the staging laparoscopy. Yeah, true.
We had sometimes access we were doing a and we did the thoracic mobilization first, and the thorax is fully mobilized, and then we went into the stomach. Then only we got to know that all the peritoneal beds there, which was not detected in the CT. Then at that time I spoke to you, I think both of you, at that time, because we were clueless what to do, whether to go ahead with that, because the whole instance is mobilized, devascularized, then he's going to take a screening, So that is where the laparoscopic staging comes in, whatever.
Yeah, it is actually a problem that we see because all flat lesions in the peritoneum mostly miss with the CT scan. I've seen individual cases like this. So when you do it, sometimes you can't. Only thing is, some of them you can clean only by touching it. This is the problem because our CT quality. We have. In our case, as I said, the CT is very much inferior to normal CT. You ask from any good radiologist, Lakmar, you ask from, he would always wait for the normal CT. He says PET CT is inferior because our quality of the PET CT is 2014. We got the machine to Sri Lanka in our city, and our one, both the slices are much different. The new one is 225. So it's like looking at things and sort of thing. So in Sri Lanka there's a problem. But even with the higher CT, unless they go into very technical detail, they can miss the practice. And so when we see this,
according to the guideline, the techniques below the diagram, you have to do a diagnosis.
That of course is of
other negative, you have to take polygonal washing.
Scenario won't happen in UK because they are doing IULV, so they will straight away open the abdomen first. So if they are not, they will go for prostate section.
The other thing is that advantage of this staging, you know whether you can pull the stomach up to the neck. So because if you have an elongated stomach, so that decision you take early. There are many things given by the staging laparoscopy.
And I read somewhere, some centers are doing, but they are doing the staging laparoscopy, they cut the left gastroesophageal artery during the staging laparoscopy and keep the stomach to survive only with the right gastric and right gastroesophageal. Then it will increase the vasculature depending on the right gastroesophageal and right gastric. So that will enhance blood supply to the when you take the gastric. As she told, they have been doing peritoneal washing. Yeah, and they have said that the staging has changed after liquid.
Now in which experience I done like maybe about over 200, 300 esophageal. I remember. But see, we had 125 in 2 years in Candy. So because there was no stage, we had operated almost every patient without CT scan. And so we did loads and loads of, you guys see, no? So we loads and loads of cases. My experience is, I think it is a very good idea to see the intra-abdominal part before you go for thorax. I wouldn't touch the thorax before doing an intra-abdominal, I did laparoscopy or something or the other. So I would touch the imaging totally. This is a bad experience and maybe we don't have specialized radiologists who are handling the esophageal cancer alone. So you have to spend a lot of time on this.
So this problem is basically with the GOJ tumors, right?
Yeah. GOJ tumors, technically, if you look at the
it takes a long time because to change the patient's position and all, but the long term.
Why you can do another lane before it?
No, the advantage is in our case, our ICUs are very, very scarce. So then staging laparoscopy, the moment you get an ICU bed, everything, you get a bed. So then it's the utter waste of facilities.
But if you are just doing a staging laparoscopy, you don't need ICU bed.
No, that's what I'm telling, sir. Then we have got the patients on the bed. So before that, we can do a staging laparoscopy very easily.
I think you should make sure that nothing is there.
NCC guidelines says GOJ tumors, they recommend laparoscopy and
basically the same thing that actually we have said, if it is a mucosal lesion, then of course the lymph node metastasis is very less. But the moment that it actually penetrates the submucosa, it goes exponentially up. You can see just SM1 is like 28%, and if you go to SMA3, almost 60%. So it's very high propensity to develop lymph node metastasis. Okay, so next slide.
T3. dysplasia will be big, but if you are interscapula thick, we avoided that because we were operating without CT scans. A lot of cases.
So basically you are looking at EMA now. Just one question here. So how many staging systems that we have? How many staging systems? Please select your cancer.
Your family
Of course
is
we have EMA, but within that EMA, how many staging systems are there? Anybody else?
There are two.
Yeah.
Because recently, the recent ENM system, they have identified not only the tumor sizing and extension and everything matters, but histology also matters. So they have different ENM systems for the adenocarcinoma and the squamous carcinoma separate.
Exactly. So you have two different systems, squamous and adenocarcinoma, and each component you have clinical, pathological, and neurological. We can give you that slide. And basically, why do you have two staging systems for squamous and adenocarcinoma? Because basically the outcomes are different. Squamous cell carcinomas, if you have a calculated comparison, if you go to the previous slides, like previous one, you can see at least in the early disease part, the survival outcomes are different between adenos and squamous. Adenos are actually better. So that's why you have two different staging systems. And then if you go to the other one, so you have ENM and then the pathological staging and then the neonatal staging. So basically, why do you want to have a neonatal staging? Why do you need so much of survival for this? Any idea? Traditionally, the basic idea of ENM is predicting the survival, and then of course prognosticating survival, and then of course deciding on the treatment options, right? But basically, why do you need all these types of, one for clinical staging, then one for neonatal staging? So if you go to the next slide, you can see it's a adenocarcinoma. So if you have P1N1, it's actually stage 2A. But if you give neoadjuvant treatment, and if that node doesn't respond, right? If it is N1, you're straight away to stage 3A, right? So your survival drastically drops down, right? So it's not a one-stop. The survival curves are not a one-stop thing. It can change during your treatment course, right? So that's just one thing that I want to highlight. Okay. So next thing is treatment selection. So now we have stage the disease. It's operable. Let's say it's operable and it's a low esophageal cancer. So what are we going to do? How are we going to proceed? Anybody?
So we have to assess the fitness of the patient, sir. Basically, lung functions and cardiac functions has to be assessed, as well as the renal functions. Those basic investigations and the lung functions and cardiac functions has to be done, sir.
So you think lung function is a good way of assessing patient fitness? I mean, of course, that's what we do. We all, everybody would have seen lung functions and cardiac functions, right? Is that the ideal thing that we should be doing? And even at the level, you should know what is the ideal thing. Have you heard of cardiopulmonary exercise test? So actually, what is important is the synchronization between the two systems. It's not how they work in isolation. It's either synchronization, and then we have to look at the anaerobic threshold. The anaerobic threshold is the single most important factor that actually drives your post-operative outcome. Right? So that's I don't know. Maybe you all are doing in those centers.
But in the center, yeah, but in the UK they do CPEX.
I think almost every center in UK they do CPEX for before surgery. CPEX for before any major surgery, they do CPEX more than 11 and the threshold is considered as low risk. If there is a treadmill or connected to the sleep manometer and the measure the CO2 and its oxygen maximum concentration and the pulse oximeter. So they connected and asked patient. So there's a, we have to get informed written consent because there's a 1 in 2,500 risk of MI, getting MI. Contraindication, recent last 5 days MI, or there are several other contraindications to the CPEX. So unless there's a contraindication, you do all major.
So MRI threshold, usually what is the cutoff?
It's 11. 11. More than 11, low risk for less than 11.
There should be for major surgery.
Yeah, CPEX. They talk about 80, that's 80 more than 11 because it is 80, 42 or something.
But in Sri Lankan setup, we don't have CPEC. The lung function test alone, the respiratory physician can predict the post-op complication rate, whether how many days, what is the percentage of he is going to stay in the ICU. Rather than just
predict. Then of course we are seeing normal lung function test. How many people are in the So another thing is, so treatment selection. Now, how do you decide, whether patients? So what are basically treatment options that you have? We say it's a resectable disease. What are the treatment options that you have? Anybody else? Other
It is early disease, we can do the submucosal resection, and anyway advanced disease need oesophagectomy.
Beyond that is anything else?
It depends on the type of the adenocarcinoma or squamous cell carcinoma. In squamous cell carcinoma, in upper third of the esophagus, it's better to go for the radiotherapy, chemoradiotherapy. And if it's middle or lower third, we can decide on chemoradiotherapy and DT discussing with the patient as well. According to the stage of the disease, of course. And in adenocarcinoma, again, it depends on the stage. Stage 1, we can do the endoscopic resection or the submucosal resection. And if it is higher than that, we can go for the...
Exactly. So as he said, not always surgery, at least for squamous cell carcinoma. It's not a completely surgical disease nowadays. You can really take it with chemotherapy. So, and one other thing that I want to highlight is, of course, your long-term outcomes are going to depend on the disease status, right? On the left-hand side, you can see what is the stage. But it's not only the factor that is going to dictate your outcomes. Say, look at this. This is age. Older people will have bad outcomes compared to younger ones, even on the long run. Secondly, if you look at patients who go into post-op complications, you go to the next slide, the picture. Yeah, so this is this one. Weight loss. Now, if you have preoperative weight loss, right, they will have poor outcomes on the long run than patients who didn't have. And if you go to the next slide, patients who had post-op complications altogether. If you develop some post-op complications, like wound complications, you need a blood transfusion, the survival will go down drastically. So before you touch the patient for surgery, there are many things to decide, many things to think of. So there are many confounding factors that come into the equation, right? Okay, so basically, then when you decide, of course, most of the operations will need some form of neoadjuvant treatment. So, what are the benefits of neoadjuvant treatment? Why do you want to give neoadjuvant treatment? Somebody else. Next one.
If it's surgical unresectable, it can become resectable. Sometimes surgery might be easy with the tumor shrinkage.
Yes, so downsizing, right? Anything else? And then you need to improve the survival, isn't it? So long-term survival, overall survival, and disease-free survival. So you need to improve your local failure rates, distal failure rates. So those are the main indicators of giving neoadjuvant treatment, right? So surgery. That's a debatable one, but then yes. It's not in practice, but I don't know.
Yeah, but even when you have a complete response with sort of neoadjuvant treatment, you can do PET scan if there is no disease you can observe. Because the complications of
yeah, not in guidelines. Not in guidelines, maybe maybe clinical practice.
Clinical response?
Definitive radiotherapy doses and the inadequate doses are different. 45 But once you use the neoadjuvant RT, then you can convert it into definitive also. There's an issue. Yeah, let's see about how you can do it.
You can do endoscopy during the after
Before the opens up your mouth. So let's start from the debates, like, now. So basically, what are the types of neoadjuvant treatment that we are like using in esophageal cancer? Basic ones. Chemo,
this squamous cell carcinoma, we usually use the chemoradiotherapy, and for the GOG, the adenocarcinoma, we use the chemotherapy.
Right. No chemo, adenocarcinoma.
There are options, sir. It's dependent on basically histology. And chemotherapy also option in the adenocarcinoma.
Okay, so we will open up the discussion. Any other questions?
Not only because of the prognosis, from the beginning, from the risk factors, location, molecular biology, and the treatment, prognosis, everything is different from adenocarcinoma to squamous cell carcinoma. So locally advanced tumors, even it is in the if it is a squamous cell carcinoma or adenocarcinoma, both need neoadjuvant treatment. The standard treatment is for squamous cell carcinoma. Actually, there are two approaches. We can go for operative treatment or non-operative treatment. So the non-operative means we can give them definitive chemotherapy, where we will give higher dose of radiotherapy with different chemotherapy regime. But operative treatment, we give them bit lower dose of radiotherapy, which is around 44 gray in 23 fractions, combination of paclitaxel and carboplatin weekly. So, then you have to do a restaging at the end of the chemoradiotherapy and assess the stage again and see whether there are interval metastasis. If there is no interval metastasis, we can go for radical esophagectomy with lymph node dissection. Right? Cross trial actually done, it's a multicentric trial, a randomized trial. They compared surgery alone with the neoadjuvant chemoradiotherapy, and they have found that there are very significant survival benefit with disease and overall survival benefit with neoadjuvant chemoradiotherapy. Actually, the surgery alone, 5-year survival was almost less than 35%, but with combination treatment, it became around 50 to 60. And other thing is the treatment-related toxicity is also well tolerable, and the surgical mortality and morbidity also, there were no difference in both terms. So that's why the neoadjuvant chemotherapy plus surgery is better. And as you all talk about the salvage radiotherapy surgery, so there are ongoing trials because there are non-randomized French data suggesting that both salvage surgery and planned surgery has same disease-free survival at 3 years, right? And but the negative thing is in salvage surgery, the anastomotic leakage is more compared to planned surgery. So because of that, there are two trials actually ongoing trials comparing planned surgery versus salvage surgery. That is squamous cell carcinomas, and definitive radiotherapy also we can follow them up as Dr. Anthony said. We can do 3 monthly endoscopies. If there are persistent disease or recurrent disease, at the earliest point of recurrence, we can go for surgery. Adenocarcinoma, yes, there are 2 options. Neoadjuvant chemotherapy, that is called actually operative chemotherapy. What we do is we give 3 cycles or 4 cycles of chemo before the surgery and do the restaging. If it is downstage and there are no interval metastasis, we can go ahead with surgery. After the surgery, we offer them another 3 or 4 cycles of chemotherapy. So that was after the MAGIC trial where they use different chemo regime. Now after FLOT4 trial, they have changed the chemotherapy to FLOT where they get more pathological response. After surgery, again we give another 4 cycles of FLOT regime. So after the cross trial, actually they included both adenocarcinomas and squamous carcinomas. So they have seen the survival benefit in both entities, but squamous carcinomas had more benefit compared to adenocarcinoma. So it is one option for adenocarcinomas as well, because cross trial showed there is a survival benefit. The big thing is cross trial actually at the end of the study they showed around 49% of patients had complete pathological response. That's why they are investigating towards salvage surgery rather than planned surgery, right?
Thank you, Tirusha.
Check this.
Dr. Anurag.
Hello, the position is prone position. Anything else you want to know?
Yeah. Yeah, Dr. Anuruddha, we can hear you. If you can explain just the positioning and
yeah,
raping.
Position is the prone position.
Right.
I don't know how to explain it any further.
No, how
can
you
you
keep
focus the camera?
Right arm? How you have left the right
arm? The aim is to retract the scapula. Retract the scapula so that we would get adequate exposure to the lateral thorax. Okay.
Right. If you can zoom out the camera a little bit. So basically you can see how Dr. Thevaraperum has marked the margins of the scapula. And also the right arm should be kept bended and upper, flexed superiorly. Yes, sir. What were you saying about neoadjuvant treatment? basically, yeah, so
I think you can
ideal
hear
in the
us.
sense now you have to make the decision, no? Whether it's
Niroshan?
an operable case or it's a metastatic case.
Niroshan?
Yeah.
Yeah, can you hear us?
Yeah.
Yeah. Now he has put the first spot.
Right.
Just above the seventh intercostal, in the seventh intercostal space, just lateral to the lateral board of the scapula.
If you
So
can
that's a
move
10
the camera
millimeter
a little
port.
bit. Okay, thank you, Tirusha. Is there any way that you all can move the camera and show the port placement?
Yeah, within the ports. Yeah, Samantha, just show the ports. Now he's using a 3-port technique. As I said, the first one at the 7th intercostal space, and the second one at third, 5th intercostal space. You can see there, and the third one a bit lower. I suppose is it 9th or 10th? Bit lower down, yeah. Usually it's a 9th intercostal space. Pressure.
This is full bro. That's surgeon's preference. Surgeon's preference. I think that was discussed.
The pressure is maintained 10 mercury millimeters. Now we are going inside, still a bit foggy. Yeah, the advantage of this prawn position, as Anirudh mentioned earlier, the lung is a bit out of way from the surgical site, and again the port locates just over the esophagus, where the difficult part of the operation. So that's the importance of the port placement as well as the prawn position in this patient. Now he's doing a bit of the survey in the thoracic cavity. So far things are okay. There are no pleural deposits. There are no visible lung deposits. Can you turn this light off, please? May light off, Kanode. Now he's going to put the second pot, which is again another 10 millimeter pot at the 5th intercostal space. Where then? We can do the dissection with 5 millimeter port there, but thing is, when we are clipping the esophagus vein to put the Hemalock in, we need to have a 10 millimeter. So we use a 10 millimeter port with a reducer. Samantha, camera. Now this is the location of the port, second port. Go inside. Reducer.
මේ ගේන්නකො මේකක් පොඩි පුටුවක් දෙන්නකො. You can sit, I think, then you'll be comfortable.
No, I'm fine. You.
Mama,
no, I'm fine.
He's too tall. He's finding it difficult.
I mean Samantha. Now the third port is putting at 9th intercostal space, the same line with the second port, the first port. It's going to be a 5 millimeter port, isn't it? And often you can complete the surgery with 3 ports, but if there's a difficulty, always you can put the 4th port. Now, as Aniruddha described, I mean, he has divided into 3 parts surgery: perizygous, supraezygous, and the yes. With the, you can see the SVC, splenic nerve, and vagus. Bit towards the esophagus. Yes, good. And he is going to show the inferior pulmonary ligament, and some surgeons start the surgery from there. But most of the other surgeons, they start dividing the zygous vein. So that's the inferior pulmonary ligament. You can see it clearly. That's the vagus nerve. It's a bit awkward portion, isn't that? Now he's going to start the dissection. The first step is to divide the parietal pleura just either above or below the azygous vein. And then clear. Now it's better. Now Aniruddha is going to use the diathermy hook for the first stage of the separation to divide the pleura. And some surgeon, of course, straight away use some energy devices like harmonic scalpel or ligature, whatever. On the case. Actually, even I find initial dissection is easier with the diathermy hook. Yeah. Yeah, the first step going to be the division of the azygous vein. So what you do is you divide the parietal pleura around the azygous vein, and then up and above and below. And of course, some surgeons even nude the zygous vein. I have seen Chaturanga operating the thorax, and he does. But I am a bit scared to do that. I think Aniruddha should do. Niroshan?
Dr. Manatunga, we can hear you.
Yeah, right. Is there any question from the audience, Niroshan?
Yeah, everybody is.
So far?
Manatunga, it's me, Chaturanga.
Yeah.
So I think, as I can see, is doing very nicely. So you know that I made two, inferior and superior to the trachea. There are two small holes in the this parietal pleura. So then I do it. So it's whatever the way. I think when we do practice one particular way, it's easy for you to understand everything, isn't it? So it's just practice sometimes.
No, this step is quite crucial because now you are dealing with the azygous vein, and before clipping the vein or ligating the vein, you have to make sure that you have dissected right around the vein. Now he has done so, and sometimes we use two Marylands from either side. It will be easier than to go behind the azygous vein and to grab it.
Hello.
Now he is telling because he is trained in Japan. Those Japanese surgeons, what they do is right behind the azygous vein, there's right bronchial artery, and they routinely clip it.
Dr. Manatunga?
You are going to ligate or clip them?
Dr. Manatunga? Hello, can you hear me?
Now he is using quite useful technique. Now he is going to put a thread around the azygous vein to get the good control, because this is quite a crucial step, as I said earlier.
Dr. Manatunga, can you hear us?
Yeah, we can hear you.
Yeah, there is a question from Isuru.
Yes, Isuru.
Dr. Manatunga, is there a particular advantage over starting from the azygous side or pulmonary side, or as the practice it is, are we practicing?
Sorry, Isuru, can you repeat it, please?
Because some surgeons start from the pulmonary ligament, as mentioned earlier, and some start from the azygous vein. So, is there a particular advantage over one over the other?
For me, I don't know whether there's any particular advantage, because even I start from the divide in the azygous face. Even Anuruddha does the same. I think most of the surgeons start the surgery there, because that's the quite crucial point. And you are fresh, and at the beginning, if you get the azygous vein, it will be, I think, easier to proceed with the surgery, because division of the inferior pulmonary ligament is not very difficult thing. It's just a matter of using an energy device. Anuruddha, do you have any idea? Yeah.
Yeah, as Isuru said, I think even I starts actually from the inferior pulmonary vein side. I don't know what Minoli and Vatsal does. We all start straight away from the azygous vein, or do we all start from the inferior pulmonary vein upwards, right? But there is no, I don't know whether there is a definite advantage.
Yeah.
Dr. Manatunga, the advantage, the only advantage I see is because when we are, we are not performing thoracoscopic oesophagectomies in a row like. So, the advantage I pursue is, so when we go to the thorax with the thoracoscopy, we are a bit new for the thoracic anatomy always. So, so doing a crucial step at the beginning, if it is not that much familiar at the beginning, so that's one of the points where we start from the pulmonary.
That's taken because I know, for a surgeon who doesn't do very frequently, to get an idea of the anatomy and to get bit of like in a cricket match, you start little slower, first play some defensive strokes, then go for boundaries that's again very good and safe technique to practice. Yes.
Suru, your point is well, I think I did the same when I was starting actually. When I was starting, I did the pulmonary ligament, because then of course you have done some steps in the surgery rather than you mess it up in the middle. So
now he has clipped the azygous vein, 2 clips either side, and
Dr. Manatunga, can you hear me?
Yeah,
This
yeah.
regarding the right pulmonary artery,
Mhm.
is there any benefit of preserving that?
Pulmonary, the bronchial artery.
Sorry, bronchial artery.
Yeah, always, if possible, better to preserve bronchial artery because it supplies the bronchus. But if it is very troublesome in your dissection, then of course, as Anuruddha said, the Japanese surgeons they routinely divide it, so there won't be a major complication. But if possible, better preserve it.
Better. Yeah. Thank you.
Now he's going to divide the esophagus with harmonic scalpel. No, anybody does thoracoscopic oesophagectomy would realize this is quite stressful the event. Are you going to go to the infrasygous part under the? Yeah. Now you start in the infrasygous dissection. What you do is you divide the parietal pleura and get into the plane. Even this part can be done with diathermy quite safely because there are no major vessels there. Only thing is there could be some direct branches from the aorta. This is the aorta. Yeah. To do a good lymph node clearance, actually, I mean, you have to go along the aorta. Yeah.
Manatunga?
Yes.
What about identifying the thoracic duct at this stage, and is it routinely done, or do you clip it if encountered, or do you clip it, do you look for it and clip it?
Now, Anuruddha, what's your practice?
Rasita?
Yeah, thoracic duct is bit lower down, is that? No, I know, I mean, there are, again, different surgeons practice different way. Right. Now he's telling this part he frequently uses the harmonic scalpel because of the so-called direct branches from the aorta. Now the Randhima's question. Now I know some. I mean, I usually don't hunt for the thoracic duct or clip it. I mean, don't intentionally clip it. But I know Chaturanga always find it and clip it. So again, there are.
The Japs generally, you include it in the dissection because it's a part of the lymphatic network. So I also actually...
there are some lymph nodes, can you see?
Proactively look for it, clip it just above the place where it comes up in the diaphragm.
Yeah, of course, yeah. Now there are some lymph nodes, as I said, I mean to get the lymph nodes out, you should not go along the wall of the esophagus, but along the aorta. You have to get all the soft tissues in between the aorta and the esophagus where the lymph nodes are. See, now. Is the tumor there? Now tumor is there.
Dr. Manatunga?
Yes.
It's me, Chaturanga.
Yeah.
So generally, I think you know, I put a sling. So it's Dr. Thevarapuram also. Is he putting a sling across the esophagus to mobilize, or is it just continuing?
Yeah, he is going to do it next.
Okay. I just want to. So he's taking some direct branches from the esophagus for the trainees too, I think. So there are direct branches coming, so it has to be taken.
So you can see the pleura on the other side. Now, you have to be very careful not to open that side.
Now you can see the pleura, the left pleura. You should avoid damage in the left pleura. You can see something bluish. See? And even the left lung. Now he's going to come from the other side. Other side in the sense anterior
many
to the
surgical
esophagus.
experience are here in the room. I think, are you happy to operate on neoadjuvant treatment given patients or without neoadjuvant patients?
I'm without neoadjuvant.
Now this particular patient hasn't had neoadjuvant treatment because his preoperative staging was T2N0.
So gas, I think, so what are the gas pressures you want, Dr. Manatunga?
We are using at 10.
10.
So that's the usual, the pressure that we maintain in the thoracic cavity. But the lung is giving a little bit of trouble. They have put a double lumen, haven't you? Now, often in prone position, we can do without double lumen. Yeah, that's the advantage of prone position, which is actually introduced by Professor Palnavelu. And so the pulmonary complication is going to be minimum with the prone position if you do it without single lung ventilation. But better always put a double lumen, and if the lungs are in your way, then of course, I mean, you can
so it's
deflate the right lung.
Quite common problem, you know, when we face these kind of things.
Anyone, why this lung is inflated? What are the causes for lung inflation on the same side? Why this? Now we have put a clamp onto the operating side. Why the lung is inflating? What are the problems? Why?
Brilliant.
Most of the time, one thing is if your tubing is too proximal, then you get a inflation. Another thing is a clamp. And again, if your tubing is too proximal, the escaping air from the opposite side can get into the clamp side, especially if your the bulb, it's not adequately inflated. Then the escaping air from the opposite side can come into the operating side.
Now this plays again very important plays in terms of the anatomical complexity.
It's a carina, isn't it?
Yes, carina, because just behind the esophagus you see the carina and left and right main bronchi. So this dissection should be carried out very carefully, because as Aniruddha said, the posterior part of the trachea and the bronchi, they are like paper thin, right? So the chances of damaging is quite high, and if so, the chances of getting major complications are again very high.
So for the trainees, I think in laparoscopy, this camera holding is very, very crucial. So because always you have to keep the horizon in horizontal. So, only you can change the light cable. That is the principle of laparoscopy or thoracoscopy. So, because when I was a trainee holding camera for my boss in the UK, he told me I get seasickness when you hold in the camera. I thought I didn't understand what he meant. Then, I realized what he meant was my camera holding was 100% bad. So that was post-SR training. So there are many defects in our training system. Because even our trainers, I think, didn't know how to hold the,
Chaturanga?
Yeah.
Now here again quite important. Now you can see the pulmonary vein.
Yes.
There.
Oh yes. Yes.
So this is the plane that we should do the dissection. Now he's doing it very nicely, and he is blessed with one of the best camera holders in Maharagama. The Samantha is holding the camera. I can remember when he was in Kurunagal, he held the camera for me. So it's like asset to have such a assistance. Now you can see the aorta nicely behind his instruments, and now he's dividing the tissues between the aorta and the esophagus, taking all the lymph nodes towards the esophagus. Put the camera is right. All right. There are lymph nodes. Now he has dissected right around the esophagus, and this is the time to put a sling.
What are the options for sling, Dr. Mathunga? There are tapes.
Now he is using, what's that? Nylon tape.
Yeah.
And you can use a thick white krill, but there should be something a bit thicker. And often,
if you don't have anything, you can use a small feeding tube as well, isn't it? So whatever, thick thread.
Even a soap should be fine, tonsil soap or something.
Attending these workshops are very important. The reason is sometimes we learn a lot. We think I came to teach you all. I learned many things. So that is how I think. It's a lot of steps are for understood and well grasped because different surgeons work differently. So why they do it, they have a reason. So maturity comes. You see how other person works. So even Dr. Thevarappiruma has taken certain steps which I have not taken. So I'm quite happy to, change my practice accordingly. So that is the attitude you need to develop as well. Randima, you put a sling across generally, or you just continue?
It depends. Sometimes if the tumor is small and easily can be detected, then I don't put it. Particularly for the bulky tumor, then of course.
No, I mean sling is not a must.
Yeah, exactly.
I mean, often you can complete the surgery without a sling. Yeah, but when you are having a sling, it's very easy to dissect around the carina. Because the esophagus is, I mean, this dissection is not very difficult.
Exactly.
This doesn't need any kind of additional support. But when you sling the esophagus, it's very easy to dissect the carina, especially the right main bronchus. Left.
I think Aravinda Disanayake is here. He's the one who started thoracolaparoscopic surgery in Maharagama when he was SR. So Dr. Kanishka Disila said he's around anytime when he's required to open. And we have been operating from 8 o'clock to 6 p.m. in the evening, isn't it, Aravinda?
So just for the trainees, I think. Yeah, actually, we were trying to do this surgery in
Now
Maharagama.
he has dissected right round and going to sling.
And then Chaturanga also came, and Sanjeev came, and we were operating at Maharagama. Of course, the first case we operated from morning to 9 p.m. I think, the very first case. But again, we improved ourselves, and we did a good series with improving all our cells. And Chaturanga was my cameraman. Yes.
Hello, Dr. Manatunga.
Yeah.
You all right?
Yeah, fine, yeah. Thank you.
So this is a...
no, once in a while what happened, because we were together, Anirudh and myself as SRs at Maharagama. So once in a while we go back to the past. Turning the mic off. Huh?
Yeah. So I just want to ask, there is quite a lower esophageal tumor, is it?
This is actually at 33.
30 centimeters. So how detailed or how extensive superior mediastinal dissection you are planning of? You want to take all the I just want to ask the operator as well.
Yeah, Anirudh, now he is asking how extensive superior mediastinal dissection you are going to do. No, he is not going to do the Japanese way. So he is not going to basically not going to do radical lymphadenectomy
of the superior mediastinal.
Standard Ivor Lewis type of lymphadenectomy.
Okay, all right.
Now we are almost up at the diaphragmatic level.
Yeah. We generally don't open diaphragm, isn't it? It's because
no,
that will
gas is going to leak to the abdomen. There are good number of lymph nodes. Can you see? So the right pleura is accidentally opened. So post-operatively, we have to put an IC tube on not the right, the left side. Routing leg.
Rasita, I have seen sometimes even when the right side pleura is not the right, the left side pleura. The left pleura, even though it doesn't open up, there is a sympathetic effusion in certain patients.
No. He's telling the same.
I, of course, invariably put one now in the theatre. Because otherwise they call from the ICU and the SHO has to go and do it in the night.
Yeah, it's always safe to put IC tube when the patient is under anesthesia.
Generally a small one would be enough. I use a 20 French.
Now this dissection again quite crucial. Now he's dissecting in the area of the carina. Now you can see the right main bronchus coming here. The left main bronchus is the difficult one because it's going to the other way. So inadvertent damages are quite common in the left main bronchi because you can see it still. Pulmonary vein. You can see the pulmonary vein very clearly.
Dr. Manatunga, Dr. Dhammika Rasnayak is also here.
All right, great. Good to have him here. So you can move the sling up and down. In this dissection, to take swing towards the carina, then you can nicely see behind the esophagus.
What about patient positioning? Chaturanga, where do you place the patient, in left lateral or prone position?
Semi-prone.
Semi-prone. Yeah. This is fully prone, isn't it, this patient? So, and Aravinda? Fully prone. I also position like Chaturanga. What about you, Isru? Semi-prone.
No, when I do, I place the patient on semi-prone position with a strap around the buttock area. So advantage is you can tilt the table laterally and get a position like almost prone. But even though the patient is in not fully prone position, you can adjust the table and get the patient almost prone position. So each position has its own merits and disadvantages.
Dr. Manatunga?
Yeah.
I think now you're about to cutting these vagus and stuff, no?
Yes.
So, leaving the twixt to the pericardium and the lung and cutting the vagus after that, will it be beneficial?
Yeah, of course. Yeah, because otherwise they are going to get tachycardia and some complications. And thing is, most of these branches are given higher up in the thorax.
It's in the
not at that level. Yeah. So dividing it this level.
That is one of the learning point for the trainees, no? Taking the vagus after the twixt to the heart and the lungs. Thank you.
But even though most of our patients after esophagectomy get tachycardia for a couple of days. Yeah.
Chaturanga, Aravind, all these surgeons, I just want to ask another question. One thing I have realized is now when we do the thoracic dissection like this and put the patient in supine position and then do the abdomen and later on finally come to the neck, it's ideal if you can have two surgeons operating in the neck and the abdomen at the simultaneously. But what I have found is that the esophagus is generally slightly to the left side in the neck. But after you do the thoracic dissection, it moves more to the right side actually. I have realized it's a bit difficult to fish it out from the neck after you've done the thoracic dissection. Have you noticed this? Because we are invariably pulling the esophagus to the right side. You know, there's some traction to the esophagus. And then later on, when you go and dissect the neck, you find it that it will move to the right side and it's a little bit more difficult to hook it out. Like, you know, if you're doing a transhiatal, it's less, yeah. Because you're going to take it out from the left side to do the anastomosis.
Actually, I feel that it is easy to mobilize once you do the thorax, because thing is that the reason is most of the time when you go beyond the esophagus, most of the people stop at the thoracic inlet. The thoracic inlet dissection is very easy through the VATS. What you have to do is you have to just retract the esophagus laterally, medially and downwards and dissect the neck. Then you can put the finger and catch the esophagus very easily if you do that part. If you leave it alone, I know that it is a bit difficult. It's as usual.
I agree with you. I also dissect up to the thoracic inlet, but you have to dissect the esophagus, the cervical esophagus anyhow. Because, but then I have realized that the esophagus is more to the right side, is deeper than usual when you're doing a transhiatal. It's not moved like that. That's what I feel. I don't know whether you have experienced, whether you have noticed this or not.
My idea is, when you do the thoracic dissection, it is easy to do the neck dissection. That is why I feel, because when we do other dissections, it's not very comfortable like that, because you have to do the thoracic inlet mainly with fingers.
Now he started the supraesophagus part dissection.
Actually, the pneumoperitoneum itself, make the dissection up. So it's very easy.
Now, Aniruddha advises not to do this part with diathermy because the trachea is close by, and yeah, that's the posterior part of the trachea, which is paper thin. I see. 24. Now we are almost at the end of the supraesophagus part dissection. You can see the carina very clearly, and yeah, no lymph nodes, but you can see the right and left main bronchi. Roshan?
Yeah.
Now he has done almost all thoracic mobilization.
Yeah.
And We didn't encounter the thoracic duct, so we are not going to prophylactically find it and clip it.
We will detect it later, I think, in the post office. So, Achala, what is your experience about thoracolaparoscopic oesophagectomy?
Of course, I don't have many experience. I have done about 5, 6. So I also use prone position, as Aravind said. I used to start from the pulmonary ligament because less risky.
Now this is how we find whether we have done the dissection completely. So that's again the advantage of having a sling. Yeah, we have dissected right around the esophagus and just
Dr. Manadhar, can you show us the anatomy, for the trainees?
Sorry?
Can you show us, walk through the anatomy?
Yeah, walk through the anatomy from the top to bottom.
Yeah.
Now here's the carina. You can see it clearly. And wait for a second, please. This is the left main bronchi. And here you get the right main bronchi. And cut edge of the vagus you can see. And this is the pericardium. Cut edge of the vagus. This is a pericardium and pulmonary vein going that way. And this is the other pleura. We have opened it up, and now you can see the lung, the left lung. And apart from that, anything else? And this vagus is intact. And you can see the trachea. So that concludes the thoracic mobilization. Now what we are going to do is we are going to put an ICU tube, 22 or 24 gauge IC tube through one of these holes and then close the skin.
So we are just going to start the abdominal part. So we'll ask Dr. Chaturanga to explain the abdominal part.
Now the surgery has taken only 50 minutes, even less than 50 minutes.
Excellent.
But thing is, because now it's a lesson to the trainees. Surgeons, the quality of a surgeon is not measured by the speed. But it's again a marker of something good. But it's not the case, because these surgeries are not very easy ones, right? In the first few surgeries, you will take at least 3-4 hours to do the thoracic mobilization. But once you are expert on the procedure, you can simply do a case within 1 hour with minimum bleeding. And well done, Anuruddha. Thank you. Opening and closing. Yeah, but thoracotomy would take more time, because now opening into the thorax, you know, it takes at least 10-15 minutes. And closing the thoracotomy wound again takes about 10-15 minutes. But this is opening and closing is simply a matter of 5 minutes. So it saves a lot of time. But again, the trainees should, even the junior surgeons should keep in their mind, these are not, easy surgeries. This has a fairly steep learning curve. So you have to be very careful, and you have to be quite slow at the beginning. And once you get the expertise, you can do it quite fast.
So thank you very much, Dr. Thoracolaparoscopic. That was an excellent demonstration. We will move on to the next segment, which is Dr. Chaturanga is going to explain us about the abdominal dissection.
Thank you. Next slide. Okay, so I'm going to do the abdomen. So I will tell what are the important steps in doing an abdomen. So everyone, it's most important thing is positioning. So we stand in between the legs of the patient. You keep the legs apart and keep the patient, you stay in between legs. So I personally would like to keep the left hand, adducted and right hand abducted. So because cameraman is on the right, left side of me, that means patient's right side, and the assisting surgeon will be on the left side of the patient. So can we go to the next slide, please? So this is like that. So I this is the cameraman, and always your screen should be in front. But in the developed countries, they have a separate screen for the assistant, separate screen for the cameraman, and separate screen for you. But in our setting, we have everything. So ergonomics is very important. Because we have to do long hour surgery. I know Dr. Thoracolaparoscopic did it in very quickly. So, but sometimes we have to get ready for long hour surgery. In long run, when you do, you might get neck pain. So therefore, keep your 10 degrees below this line. So try to keep 10 degrees below your screen. So, and you should not be looking at like this. So you should be in a very straight position to the screen, at least the surgeon. So other people might have to compromise because of our less facilities, as we are doing with only one screen. So this is the position, this is the surgeon's position. Can we go back to the previous one? Yeah. Then the port placement, right? So what are the ports we are going to do? Can we go to the next slide? Next one. So I generally go at the umbilical level, but what important thing is, like if it is very, very, there are certain people with very long ciphisternum to umbilical length. But in that patient, I might go supraumbilically or about 1 inch above the umbilicus. It depends on what you feel. But once you put the port in, so what I look for is the low margin of the greater curve. So with my right port, I should be able to take that lift and take that part easily. So that is very important thing. And I put a 10 millimeter working port, that means on left side of the patient. So hand's breadth, that is my length. I generally keep hand's breadth and keep a lateral port. So you can do with a 5 millimeter port, but as I'm going to put some hemolock, etc. So therefore I would like to have a 10 millimeter port. So if you have a 5 millimeter hemolock, your hemolock is 5 millimeter, you can just completely do the surgery only with 5 millimeter port on this port as well. So this is a 10 millimeter working port. There's another port, it's about just below the rib cage on the left side. But very important thing putting this port. So your rib cage might act as a fulcrum. So, because when you put this port in, and you should be able to reach the GOJ without any problem, right? So, because in certain patients there can be scaphoid chest, so you might be struggling, your movements can be restricted by the rib. Please be careful on that. If it is so, just put it slightly below, right? So that is the working port, that is the assistant surgeon's working port. Then there are several other ports depending on the liver retractor you have. So if I have a Nathanson liver retractor, I put that port in epigastrium. But if I have no Nathanson, what are the other options? So have you seen Cusheri retractor? There's a ring-like thing you can press. So that is called the Cusheri retractor. In that scenario, what I used to do is, I put, like in the gallbladder, lateral port at the level of the umbilicus, generally, and I can lift the lever, left lobe up. So it is important, your aim is to reach the GOJ without any problem, right, with the liver retractor. I'm not a fan of fan retractor because it is traumatic to me. I generally don't use that. So if you don't have fan retractor, if you don't have Nathanson, you can just take a grasper, like a fundal grasper for the gallbladder, or else suturing needle holder, and you can hold the right cross at the top end. You can put it at the level of the epigastrium, and you can lift the left lobe up, right? So there are a few things which I'll show you while I'm going to do the demonstration. Can you move the next one, please? Okay, so I have a small video which me and Manathung, I think, did this surgery. So I think, this is the, this is where we have entered. Okay, so this is what we need to observe, because this is the most important thing, right gastroepiploic artery. So for the easiness, if I look at the steps of this surgery, one thing, positioning. Second thing, port placement. Third thing, peritoneal survey. Just with one hand, you should be able to see everything in one go, to see the liver, see the peritoneum. If needed, you can take some biopsies. And then you lift the liver up and see anything underneath your liver if there are metastases, right? So then, I asked when I went to training in the UK, what are the steps of this surgery? So, Chaturanga, this surgery is very easy. Why? It has only few steps. So, what are the steps? Greater curvature mobilization, lesser curvature mobilization, left gastric artery, and the hiatus. That's all. So, make it simple. You make the surgery simple. It's like doing a gallbladder. So please always remember to make the surgery in simple steps. So I am trained to do greater curvature mobilization one day. Next day I am given to do the lesser curvature mobilization. And along the greater curvature, sometimes, reaching the pylorus is a bit difficult. I'll show you how I'm going to do it. So that is another step. And taking the left gastric artery. Either posterior approach, you lift the stomach and take the left gastric vessels, or in same position, you can take the left gastric vessels as well. So, yeah, please. So this is where we stop there, right? So very important thing is go behind and make the, where I'm going to start. I generally start on the greater curvature side, and I go to the thinnest part. I lift the stomach up and enter into the lesser sac in that place. And most important thing is checking the right gastropubic artery every step you take, because every step you take, you might be reaching right gastropubic artery. I think I'm going up, right? So we'll be seeing these things during surgery. Okay, that is one step. You can lift the stomach up with the grasper. I think we are not very clear, isn't it? Fine. I think I'll show you these things. Show you where this is the lesser curvature mobilization. So the mistake what I do, just stop there. So I'm not taking this adequate part. I'm doing a cancer surgery. So ideally, I should have taken this leaf as well into the specimen. So please correct yourself with each step you do. So this is I should have done more justice to the patient, right? Okay. So this is the, okay. So this is the right cross, you can see, right cross mobilization. Okay, so this is coming to where there's a merge between the transverse mesocolon and the anterior leaf of the omentum. Please only take the anterior leaf of the omentum when you're reaching the pylorus. So that is very important, because otherwise you might end up in making a hole in the transverse mesocolon, right? So go up to the gallbladder, don't hit the gallbladder though, right? So do we need to do a pyloric cockerization? Sorry, duodenal cockerization? Generally no. Your generally the length is adequate, but if you think this is not adequate, please do so. Okay, fine. The posterior stomach, there are few steps. You might encounter posterior gastric artery. So we have to take that as well. So this is the left gastric territory, so which I'm entering. So always left gastric vein lies anterior to the left gastric artery. So anteriorly I'm trying to take it. You can see it's just skeletonization of the vessel. Skeletonize and little more. He must be Persian. Fine. So I'll show you something which I did really stupid on this patient. So it has to be skeletonized. It has to be taken separately. Left gastric vein and left gastric artery. So to save hemologs, okay. Okay, so I did it. Let's see. Okay, so I did this. I did that. Another clip. Okay, so I assume both left gastric vein and artery on this, and then put another clip. I cut it. Cut it. it's bleeding. So, it's bleeding. Why? What is the mistake I did? I forgot there's an ascending branch of the left gastric artery. So, ascending branch and descending branch. Descending branch comes towards the lesser curvature. Ascending branch, esophageal branch goes up. So, with my clip, it did not pick up. So, please always remember it has to be taken separately. So, proper way, I think I have mentioned. Next. Yeah. So, it is to take the vessel separately. So, for all the trainees, because when you are learning, so I was told, when I was doing the gallbladder, I was told, skeletonizing the cystic duct. So he didn't allow, my consultant didn't allow me to clip the cystic duct. Say, skeletonize. I said, I can clip now. He said, no. Why? This is your training to clip the left gastric vein. So that is how they train you. So I never thought about it, but this skeletonizing part I learned from cystic duct skeletonization. So it's called systematic training. Okay, fine. That's it, I think. I think I told basically stop. If you are doing Ivor Lewis, please do the hiatus last, right? Because the moment you damage anything around the hiatus, you might have to stop the procedure, or you might have to, you can't do the laparoscopic dissection. Therefore, do the hiatus last, right? So, always make the surgery into small few steps. Like as I told, peritoneal survey, port placement, positioning, port placement, greater curvature mobilization, lesser curvature mobilization, left gastric vessels, and the hiatus. So these 4 steps, esophagectomy is very, very easy. So that's how I think. Thank you. I'll move to the...
So thank you very much, Chaturanga. I think that was a good explanation. So I knew that, this is a very easy case for Chaturanga. So that's why we selected the patient with a midline scar. So he's going to have a tough time there. So let's see how he's...
I usually start from the hiatus region and the lesser curvature, because when I dissect that, the air will seep and there will be a good plane. So it is much easier for me to get the greater curvature in that case. If you first do the lesser curvature and the hiatus region without opening up to the thorax.
When you are dissecting around the hiatus, if you accidentally open through the hiatus, then of course there will be air leak into the thorax. So, yeah, then you can do it, but you will find little bit difficulty. But otherwise, I don't see there's any difference between going through the lesser curvature or the greater curvature first. I don't know. Any additional?
No, I mean, I follow the Chaturangas because we often operate together. I mean, there, as Minori said, she started with greater lesser curvature mobilization, and her explanation is when the air seeps through, the mobilization of the greater curvature would be easier. I mean, surgery is like that. I mean, different surgeons use different techniques, as everything in the life.
Dr. Aravinda, do you do the same thing? Basically asking, now we were talking about CVAT2 cancers, and so the one question is what type of surgery that we should do, whether we should do a gastrectomy or whether we should do a esophagectomy. So, and she's asking whether there is any survival difference between the two procedures. Randima? There's a severe 2 tumors. What should we do? We should do a esophagectomy or a gastrectomy, basically.
So that's the gray area. CVAT1 easy to say it's esophagectomy, CVAT3 gastrectomy. But CVAT2 lesions, I personally prefer to pull the stomach up to the neck. So I do an esophagectomy because it's safer than having a thoracic anastomosis, I feel. That's the reason. Or you can anastomose the lower esophagus by doing a gastrectomy, but I prefer to do an esophagectomy and pull the stomach up to the neck. It's not evidence-based, but this is my personal preference.
I think overall there's a little bit of change in the management because in SIVERS 2 they recommend chemoradiation. Only chemotherapy. No, yeah, I spoke to a couple of oncologists. What they say is if they can spare the splenic radiation and oh yeah, because if we can. It may be because of, but in standard practice, they recommend chemoradiation as well for adenos. But there's another way of giving only chemotherapy. The reason being, with radiotherapy, maybe with our machines and all, they can't spare the important abdominal organs, like especially the spleen. That's why they focus on. Yeah, that's the thing. That's the reason sometimes they avoid chemoradiation, but give only chemotherapy. But some in the standard practice in other countries, I think they use the chemoradiation for STUART 1 and 2, not for 3.
As I think as Randima said, there are no kind of direct prospective trials looking at gastrectomy versus esophagectomy. But then what is evident is if you look at the lymph node distribution, we will show a slide. Now, even if you have a severe 2 tumor, there is a 27% chance that you will have mediastinal lymph nodes. So that, there is a rationale that it's better to do a esophagectomy with lymph node dissection. Because, these trials were done back in the days, when esophagectomy has a very high mortality. So that's why people were actually going for gastrectomies those days. So, Megan, yeah, this one. So you can see SIVER 2, you have nearly 29.5% mediastinal lymph nodes. So, which means actually, up to the carina level. So, which is rational to do a esophagectomy with lymph node clearance. Ivalovisia. What do you think?
Now, if you take SIVERT 1 is straightforward, SIVERT 3 is straightforward, we go treat as a gastrectomy. But SIVERT 2 is the arbitrary area. So what say in the Japanese, they think in Asian population, SIVERT 2 and 3, they more behave as a gastric. But the European, but even if we take NCCN, they for the SIVERT 1 and 2, they recommend esophagectomy. But even Japanese guidelines, they recommend treat as because of the Asians, they think this behave more like gastric, so they suggest. But there's no hard and fast rule. There are no exact studies to say because in SIVERT 2, lymph node, it through the wall, it is spread upward and downward both. So if we are going to take up to the subcarinal level lymph node, so we need to take up to the subcarinal level, and also we have to, if it's like SIVERT 3, we treat as D2 with the D2 clearance. But ultimately, the answer is, as you all mentioned, there's no hard and fast rule, but we need to take adequate clearance and adequate 2-field lymphadenectomy and the good anastomosis So as long as we can achieve that, that may be the surgeon's preference.
And one other thing actually we were want to discuss is like, whether we should do a transthoracic oesophagectomy or a transhiatal. Is there a difference between the two procedures in terms of survival? So, Minoli, what do you think?
I don't know whether everybody will. Yeah, everybody will agree with me, but I think there are no randomized control trials comparing transhiatal versus transthoracic, but the available data says there is no difference.
There's a Dutch 3 trial. Dutch 3 trial, what they say, they have compared transhiatal as well as the transthoracic and sometimes and the thoracoabdominal approach as well. So CVAT 1, 2 and 2, 3. There's one advantage, obvious advantage is transhiatal, less respiratory complication, 56 versus 23% like that. So that's a significant. But lymph node clearance is more in like thoracic, but we don't know whether we need to, is there a survival benefit by taking the lymph node? That's another point.
So that's the thing now, this is always the clash between the Western and the Eastern world, always the clash. Now you can see, if you get into that slide, now there is evidence actually to show now doing a lymph node dissection not only is prognosticating, but also there is a survival benefit. So before that slide, before that one, this one. So this is a kind of a meta-analysis, which they have shown that, by doing a lymph node dissection, there is actually a survival benefit as well. And then the problem of whether it's a transhiatal or transthoracic, again the problem is, if you look at Western studies and Eastern studies, Western studies, most of the cancers are like T4, N2, N3 disease, which means always is locally advanced or almost systemic. So whether you do a transhiatal, transthoracic, whether you do a lymph node dissection or not, it's not going to matter. So disease is systemic. But when you look at the studies in the Eastern world, they have screening programs so that they detect the cancers very early in the stage. So for them, doing a lymph node dissection, there is a survival benefit. Now you can see stages.
Yeah, because like in UK, they don't even because they take cup of a rim around the diaphragm. Even like you don't expose the esophagus. If you expose the esophagus, let's say, no, there's a mesentery around the esophagus, you have to take that cup as well. But we usually expose the esophagus and take it without that lymph node.
So you can see here, T3, almost if you have T4, T3 and N3 nodes, we are almost talking about 4A, stage 4A. So it's almost like systemic disease. So basically improving on the local treatment is not going to help on your survival. So that's the problem with the Western studies. But if you look at...
Yeah.
Exactly.
Yes, they recommended. They go for lymph.
Yeah, but that is for prognostication, isn't it?
3.
Yeah, but you will recommend the lymph node dissection for two things. One thing is to prognosticate, one thing is to see whether there is a survival benefit. But in this case, they are actually recommending for prognostication. But even with colorectal cancer, you need like 12 lymph nodes, 15 lymph nodes, right? Yeah. Exactly. Yeah, there might be. Yeah. That's the thing, these guys they are showing survival difference.
Japanese.
That's the problem. Now, even if you see the Japanese guidelines,
yeah.
Yeah, this one. See, now they actually look at the esophageal involvement. If there is more than 4 centimeter involvement, they will recommend actually doing a full lymph node dissection.
So even like that is why for the Sievert 2, they say if you can take a adequate length and the two-field lymphadenectomy and good anastomosis, sound anastomosis.
Yeah.
So that's the principle. So they consider two-field lymphadenectomy. The lymphadenectomy has a benefit.
So that's why. So basically, Sievert 2. Actually, I think we are moving more towards esophagectomy. That's the thing.
Yeah. They take both.
Anyway, they take the lymph nodes out.
So what's the other, like, what do you think about?
Stapler, circular stapler, you can use it. So medius,
It
nothing
leaks
happens.
usually.
Nobody dies. That's the thing.
What do you do if leak? Yes, what do you do?
Huh?
What do you do if it leaks? Usually, if it is small leak, what do you do?
It will come through the IC tube. It will come through the IC tube. Huh?
No, there's a place you can exteriorize as a T tube. With a T tube with the shortest distance, for a small leak in the UK centers, but they do I agree with you. Most of the surgeons they go for IVLUs. So a small leak, what they with the shortest length, with a T tube, they exteriorize as a fistula. If it's small
So
leak.
they put the T tube through the hole.
Through the hole. And purse string and exteriorite.
But if it is a controlled fistula through the IC tube, then of course you don't have to do anything.
No, but that's going to be a control fistula. From another end, shortest length, you take the shortest length to the wall and put the T tube through the hole. No, they do open it. They go because they usually go for because there's other controversial whether are we going for a total minimal invasive or hybrid, because there are systematic the control not randomized studies and systematic reviews. What they are one major review, they say it increased the morbidity and anastomosis leak with a total minimal invasive. This is a point for a debate. So there's evidence for against as well. So what do you all think about that? I want to ask that as well. Total minimal invasive versus hybrid esophagectomy.
Most of the time we do hybrid because there's no enough of time. We do the thorax laparoscopically, then we do the abdominal part, but I don't know about the evidence actually.
Yeah, you better read. Because we think it's a total minimal invasive is far superior, but there's a other aspect. Some UK centers, their surgeons specifically say total minimal invasive. They don't go purposefully, and they go for a hybrid procedure because there are some studies saying it increased the morbidity and anastomotic leak rate. But there are studies against as well, just for it and just for your concern. Either one have to be open, either laparoscopy or thoracostomy. Yeah. But when you do thoracoscopy, it's difficult to anastomose. How can anastomose? You mean intracorporeal surgery?
So this is IVLUs. We do the anastomosis in the thorax.
I used to, I asked the surgeon to send the patient to us because then it is easy to manage. Getting the pull the drain little by little and making a controlled fistula, but very rare in very few cases. Just staple the stomach tube. These things happen that they are septic and ultimately they are
because you are thoracic surgeon.
Obviously,
because you are
thoracic surgeon. No, what about one thing, Nadish? What is the place of a stent, intraluminous stent? No, only thing is
it
now,
will not heal with a stent. Yeah, covered stent you can for a minor, but it will expand.
Will it retain?
Erosion?
No.
Hello?
Narrow gun.
Can you all hear us, Niroshan?
Sorry? Yeah.
Can you hear us?
Yeah.
We are going to proceed now.
All right, okay.
So, for everyone inside the auditorium, as this patient had a laparotomy, so I generally, either go supraumbilically or subumbilically. But in this patient, I would like to go lateral umbilicus because in case
Neck leak. This is for neck leak or mid thorax?
Erosion එහෙනවද?
Hello? Niroshan?
Yeah.
Can you hear Chaturanga?
No, we can't hear him.
Maybe there's a little problem with the microphone. Now, he said as this patient had laparotomy earlier,
yeah,
usually he goes either supraumbilical or subumbilical, but here he goes lateral to the lateral
okay.
Paraumbilical.
So it's an open entry definitely. Can you hear Niroshan?
Yes. All right. Yeah, Dr. Manatha, we can hear you.
But not
Chaturanga. Yeah.
Can you hear me now?
Yeah, Chaturanga. Yes.
Okay. So it's definitely an open entry.
Right.
Because of the laparotomy, so I made with an open entry. Just now it's time to pray Niroshan.
Right.
Pray for me.
Yeah, we are all praying for you.
Yeah. Done. I think we are okay. Stomach is there.
Have you seen?
Yes.
Oh, okay.
God, thank God, stomach is there. Okay. Gas on, please. Go low flow. So always, go low flow because high flows can suddenly give rise to bradycardia and complications, and you have to keep in touch
Turanga, this fluid that is inside the abdomen can be because the thoracic duct is clipped in the thorax. So then it causes a retrograde sort of a lymphatic obstruction, and there can be some mesenteric lymphedema and all.
Okay. So I can see there's a small addition there. That is a bit of a worrying one. It's in my heart. So
Chaturanga, are you put now when you are putting the camera port, so you always select the umbilical side, supra or infra, or you put little lateral to onto the left side?
actually I'm in the lateral side, Aravindan, you are
Yeah,
correct.
yeah,
So I'm in the left side of the abdomen, honestly.
yeah. Actually, when I was doing from the beginning, I did the same from the umbilical port, but then when I worked with Dr. Amal Priyantha, he trained me to put it to the left side, about 2.5 to nearly 1 inch left side, because it
Align with the hydrus. Okay. So we are placing the Nathanson retractor. So it takes a little bit of time, but it makes your life very easy. So there's a little bit of additions on the greater curves to greater curve to yeah. So can see there's a addition. So I'm in the infracolic compartment. Yeah, the podi. Yeah, okay, podi ara pura barak barak. So as there's a laparotomy, there's a addition on the which I have to be careful, because I need to be certain that gastroepiploic vessel is safeguarded. So it's not the normal anatomy, but we will manage. So I generally can go in thin areas sometimes. Bit of a risky thing, but so to visualize this, I might have to put a temporary another port, and I'm going to dissect that part out, because I can't see from umbilical port. There's an addition which is dense addition going from suprapubic. I'm going to put an additional suprapubic port temporary for the camera, right? Because this is a laparoscopic case, so you should not panic. Yeah, definitely yes. So it's from Kalubowil, I think. Withdraw කරනවා පොඩ්ඩක්. තව අපිට 10 port එකක් ඕන වෙනවා. පස්සේ අපි ඒක අයින් කරනවා. ඒක වැදිලා තියෙනවා. Okay. Yeah, I totally agree. It's it makes your life very easy, isn't it? Because it can see I had to put an additional port because you can see an addition. So because I can't take that addition without that. Okay, so this is the addition. So I'm going to use the other port, which my working port. So I'm going to put that working port hand's breadth, exactly a hand's breadth, because otherwise I'll be sword fighting. So, and I'm trying to come from above downwards to releasing this addition. I'll be trying to stick to towards the wall side rather than the 10 port එකක්ද දැන් තව එකක්ද we අපිට එක temporary we'll use a 5 port. Okay, right, so this is the addition we are going to separate. Right, මට harmonic then. Yeah, yeah, yeah. With Thompson? Okay. Okay. Okay නේ. දැන් මට මේකේ මේ අනිත් පැත්තට අල්ලන් ඉන්න. I am dissecting towards myself, Aravind. It's a bit of a, because I didn't want to put additional another port, so I'm trying to, okay, stay with this one. Is it, which part of the stomach? This is colon. So it's a very hard structure. Okay, support I think. Yeah, on the pelviform. Is it the pelviform? Okay, withdraw. I have to get a window, small window. What take a din liye? Acha rehne. Yeah. Can see we made a small additional port, supra pubic had to be put just to make sure, so we get a good weave. Okay. So this is not a addition. This is again. So it's an addition. It's not the falciform. So it has to come out as well. So only thing is, are we? Yeah, I'm going to halfway split 1 point. I checked from both sides whether there's it containing any bowel or anything. So it looks fine to me. Actually, I didn't put the other ports because I want to assess the anatomy and and put the other ports rather than just putting everything. So therefore, I don't get an adequate retraction, additional retraction here, but still manageable at the moment. Okay. Because I might hit the gastro. You can see, gastroepiploic vessel is very close by because of the adhesion. So therefore, always what I told you is to stay close to the abdominal wall. That is the principle. So we stayed close to the abdominal wall, and we survived. I think for all the trainees, it's in case if you have adhesions should be separated closer to the abdominal wall. Okay. So Niroshan, I think we can take a small breath now. Okay. Right. Excellent. Hari. So fine. Right. So we'll go from the porta bar. Okay. So Nathanson, can we put the Nathanson now? Right. Okay. Look. Right. Okay. Thank you. So show me. Right. Okay. Local, please. Local or any comment? Need like a pen? Yeah, when you put the Nathanson, look at the liver edge. That is where we are going to lift. Okay, so that's it. Scalpel, please. Okay, thank you. So you can put a port. In this patient, as he is very thin, I directly put my right. Okay. So okay. Okay. So yeah, so outside we apne eliye podda weave ekada. So actually Randima, so this is our Nathanson, right? This is our Nathanson. This is the camera port. This is an additional port which I used to, generally we don't put this port, suprapubic port. So this is exactly hand's breadth roughly from my insertion. You can see the nice midline laparotomy scar. I went on the left side, Aravinda, as you mentioned. So that is my working port, first working port. I'm going to put additional port on here, right? So my working port, another working port on my left side at this point, right? So this is 10 millimeter which I'm going to use, change into 10 millimeter for, I don't want to, you can do it, but only thing is then hemologs and stuff you need to struggle. So always when you put ports, keep your skin as a holder, right? Don't make big cuts in the skin. So then it comes in and out and you struggle. So we are showing the lateral port to Vibhuti. Vibhuti is assisting with the assistant surgeon. Camera holder? Samantha. Okay. So local then for Vibhuti. Just to make sure that it doesn't hold the rib cage, I think, because it doesn't act as a fulcrum here. So, okay. Excellent. Right, scalpel. 5 port, keep 5 port ready. Skin incision just to be adequate. Okay, right, fine. Thank you. Excellent. Okay, so another port here. Put one another. This is a working port. Alien put up in another. Yeah, okay, we are there. Okay, fine. Right, so we have already put all the ports necessary. Okay, so now next step is greater curvature. So you can see the left gastric vessel. So and stomach is elongated, nice stomach. So camera holder please, yeah. So I want Vibhuti to hold the colon and take it towards him. Bowel grasper to my right hand, so left hand. On the bowel grasper, short bowel grasper, right, ekamata. I like short bowel graspers without ratchet, right? Some people, like Dr. Manatunga like ratchet, isn't it? So it varies from person to person. What you need to realize is, there's no universal way of doing a single thing. Can I have the harmonic, please? Yeah. So what I'm going to see is the vessel, whether we have done any damage. So can you lift it up, Vibhuti, here? So I can see we have to go use the advantage. There's no 100% one way of doing this thing. So I saw a easiest way to reach the lesser sac. So I'm going to start from there. So generally I'll start a little lower than this, but in this patient I would like to start from here. So it's a gentle movement from, okay. So Vibhuti, if you hold it, right? Yeah. Okay. So always I see whether I'm reaching the. Then other thing is that this blade, you can see the Teflon. Don't push beyond the Teflon, right? All the trainees, please don't. There's no point. It's just charring. It won't cut. So slow. Don't do it fast also, because there's no need to do this fast, because you do a nice dissection and turn the blade accordingly like this, right? So I might have to change the mode to little slower mode, because I am reaching now, I think, okay, so left gastroepiploic vessel, or I may be reaching the short gastric soon. So I don't think this area is not much vascular. So another way is to go there and yeah. So it's traction and counteraction. Actually, when I was in the training, I was told this surgery is done by the assistant rather than the surgeon. Because if you get a good retraction, so I mean that is the most important thing. He has no spleen. Very correct. He has no spleen. He had a splenectomy. Yeah, it is so. I think we are reaching.
We have selected the correct patient.
Exactly. So no short gastrics. Come forward. Yeah.
Niroshan. Hello.
Right. So you can see the rhythm, right? So I wanted to show one side, and Vibhuti quickly pushed the stomach down. So he knew what I wanted. So that is the most important thing in this surgery, right? So actually, what is this part? It's a part of the stomach, isn't it? Okay. So always listen to the assistant also. They are telling it's the stomach. So I should not cut the stomach. Okay. Take it slowly. This is now, it's going to bleed because it's short gastric. Slow burst. Don't push the harmonic. Okay. So these are additions, I think. When I am doing an oesophagectomy, I generally don't like to hold the stomach a lot. I try to, retract and do things. Okay, come forward. Yeah, show below. Lift your hand up. Okay, so I think this is where so I might encounter posterior gastric here. Okay, so I think spleen, no spleen. Okay, so it may be short gastric. So I'm going to go to slow mode again. Come forward, please. Okay, so you can see it's bleeding. අපි stomach tube එක හදන්න ඕන නේද? We have to make the stomach tube inside there. Take little time. Okay, so I'm going to stop at this point, right, and then come back and go on to do the lower part of the greater curve. So I'm going to hold here and lift it up, and Vibhuti can just, yeah. Okay, so he's doing a fine, retraction for me. යට දාගන්න Vibhuti. Am I reaching the vessels? We have another additional port now. You can use it for the advantage, which I clean it, please. Yeah. Generally, yeah, it is a luxury. So it worked for me. The port I put started helping me. So careful on this, because I want to take just the anterior layer. Then I will assess, and if I need to, I will take the other part. This is what I told, the anterior leaf dissection. So of the gastrocolic omentum. Vibhuti, can you put this thing down a little bit? Yeah, sorry. Okay, it's very, very thin. This guy is, tissues. You can see. This harmonic is helping a lot, actually, because you can put into any place and you can separate very nicely. Pylorus. Come forward. Yeah. So the aim is, when you lift the stomach, when you make the stomach tube and lift, transverse colon should remain below. Transverse colon should not raise. So this is done by this dissection. You have to show from the... Yeah, okay. Yeah. Okay, camera turn. This light source turn karan 11 o'clock. 11 o'clock. Yeah, now come forward. Just take the anterior leaf. Don't take anything more. Okay, Vibhuti, can you hold my one? Just away. And I'm going to hold this part. Okay. You can see the duodenum. So we have already reached the duodenum. You can see the pancreas below. This is the pancreas. Okay, come forward, come forward. Okay, so but I want to now visualize the vessel properly, and because it doesn't hold properly. Yeah. So Vibhuti, can you put your thing here? Just we'll go back to basics. Don't hold. Okay, fine. Right. Okay. Let me grab it. Take you on. Just okay. Karnahari. Just hold it. That's enough. You can see transverse mesocolon is merged, isn't it? Or do we have to do a little bit more? Come forward. No, keep it in one place. Yeah. I can lift the posterior and see whether my dissection is adequate or right. So this movement gave me some room for me to camera withdraw a little bit. Yeah, okay. What I want to see, I can't exactly go. Yeah, we will take this, no? You can see the gastroepiploic vessel. This is the gastroepiploic vessel. So I might make a hole. That's the thing. I'm a bit worried. That's why. This is a fiber by fiber dissection. It just okay. So can we come back? Come back. Because of previous additions, it make things little unclear, but it's just matter of taking time and slowly dissecting. So I might hit the pancreas. Yeah. So I don't want to, because this I'm leaving that layer. This thing. So I'm going back. I want to hold. No, I want to hold it from the posterior. Yeah. Excellent. Yes. Very true. So can you hold it for me and give it to me, Vibhuti? Yeah. So I wanted him to hold and give it to me. So he just, this is like a combination. Like, so, right, done. Am I okay to take this? Okay, no? So just asking. It's important, like having conversation with because if your assistant, like in case if you are a big boss, like if you never listen to others, they won't tell you even if you're going to hit a big vessel. They keep quiet. So I think, shall we leave it or leave it? Leave it for the moment, yeah, true. So you just leave it for the moment, okay? So can we look at the vessel again? This is the vessel, isn't it? So yeah, that's what I'm trying to do. I saw this is the vessel. This is the vessel coming down. Yeah. I think I'll leave it. I'm not going to do anything for that vessel. Okay, can we go from above now? Come from above. So its next thing is clean it. Right. Next thing is Vibhuti, can you slowly? Yeah. Okay. So this is the What is this vessel? A big vessel. Yeah. Yeah. I'm going to safeguard gastric. So Dr. Manatunga says to save right gastric vessel, right? Because we don't know, he had a previous surgery. So okay, this is what I am trying to tell you. Go closer to the liver, right? Go closer to the liver, right? Try to take all the vessels. Okay. So here you generally come across accessory hepatic vessels. So you just check whether it's a very, very big one, unless you can just take it out. Okay. So now next step is left gastric territory. So what I'm going to do is I'm going to lift and see. You can take this left gastric vessels from anteriorly or you can take it from posteriorly. So see what I'm going to do. I'm going to give this to Vibhuti to hold it. Is there anything bleeding? Sorry. Here. It's bleeding here, I think. Sorry. I think it's a... Right. Okay. So withdraw camera. So go to this origin. My God, what is this? Is it the? I don't know what this structure. Portal vein? No. What is this vein? Oh God. So Niroshan, we get all these abnormal structures today. Right? So, oh, so can you, yeah, make it straight. Okay, what I'm going to do is, I'm going to go closer to this one. I'm going to take, which I showed you earlier. So use your instrument in a way. Okay, come closer. Yeah. If you have a green hemlock, that is the best, but unfortunately we don't have. I mean, not even in the places I worked here. So it's like this is a very good dissector. I use harmonic blade as a good dissector. Okay, come back. This is the left gastric artery and this is the left gastric vein. So see, these are the movements you need to, as trainees. Node is there, no? There's a node. Come closer. Lift your hand. Yeah, that's it. So you can see it's burning. Keep it there and see it's burning. It's hot. I'm trying to take all the fat tissues towards the specimen. Okay. Another node here, another node here. So always try to do a sharp dissection, right? Always try to do a sharp dissection. Come from there. Now show me camera එක පෙන්වන්න මට 1 o'clock position. Excellent. So you have to use your camera in different directions to reach different expectations. Okay. Are we okay to clip? Not yet. So we need to go completely clear this. So can we get the Maryland, please? So Maryland coming. That's okay. You can just consider it there. So this is the artery and this is the vein. So I'm going to make a small gap in between the artery and the vein. Are you happy? Yes. Okay. So ideally, these ones also should come out when you are practicing. Okay. So these ones even should come out, right? Okay. Clip please. Hemolock. No, just hold it. Okay, another one. Right, okay. Right, okay. Always center. You don't need to show how it is coming. Scissor, please. Reducer and scissor. Thank you. So I'm okay with one hemolock there. But don't cut the left gastric artery. Okay. You have clipped only the left gastric vein, so it's a crushing one, na? Okay, right. So just that's all. So then the next is the left gastric artery. So we have done the left gastric vein. So these movements I tell you for the trainees, like very slight movements, will show you that how many laparoscopic cases you have done, right? So always remember, right? Never do blindly things, never change your hand direction, just change the instrument, like so, like these movements, okay? The moment you hold, so my UK trainer told me, I can guess how many laparoscopic cases you have done just by watching how you proceed. So, show me. Right, 11 o'clock please now, view. Okay. So I want to see whether I have done, do I have to take any more here? No, I don't think at the moment. So this branch, am I okay to clip completely? You can see slightly the ascending branch going, okay? So slightly the ascending branch going. So the mistake I did was which I showed in the video. Something happened the monitor, okay? Right, it's come back. Hemolock please. Dekai, ekai. Okay, go to the base. වැඩ කරේ නෑනේ. මොකක්ද දන්නවද? Yeah. Haha, yes. Just change the direction. Don't keep on crushing the vessel, please. So I think I pushed extra pressure on the vessel. That's why I didn't pick up. Always when they are giving a hemolock, check whether it's in the correct groove. You hear the click, you feel it. Another one, please. I didn't hear the click, or I didn't hear the soft tissues. මොකද්ද වෙන්නේ? ඔයා move වෙනකොට මේ screen එක මේ වෙනවා. When you are going here, මොන හරි vessel එකක් ඔව් මොකක් හරි. So what has happened? I will check the hemolock. No, මේක ගැලවුණොත් එහෙම මල බම්බුවක් වෙනවා. හරි, කැඩිලා. මේ කැඩලා තියෙන්නේ ඒකයි. Click වෙල නැත්තේ ඒකයි. So always, if it is not clicking properly, something really wrong. You have to check whether it's in the correct groove. Clean it, please. Yeah. Yeah, with the click. So it's complete. Reducer. And cut in between. The mistake you do, you can cut the hemolock, right? People have cut it. So not that they are not careful, but you know, you are very, very quick. You want to do things, you know, when you want to do things fast, you make mistakes. Doing things slow will make your speed. Okay? So this is a mistake. You can, if I cut like this, sometimes I can cut the you know, hemolock. Okay, done. So, Vibhuti, can you pull the, you want to take that one out? Yeah. Okay. So, actually, This is the hiatus which I could have dissected little. I generally tend to prefer to come to hiatus last. One reason is because I have already finished my dissection there. Okay, so he has done a very good dissection. It's I think Dr. Thoracolaparoscopic has done my life very easy because I am already in the thorax now. So thank you very much. Come closer. Yeah, come closer. Excellent. Okay, withdraw. So we might have to do a little bit of more from this side because posterior dissection I am not very much happy. Bleed another. Just check whether there is any bleeder. Previous bleed. No. Okay. Okay. Here. So hold this like this. Change your directions of the graspers accordingly. Slightly rotated. Yeah. Come closer. Come closer. Slightly rotated. Okay. 10 make it chutta. Yeah, that's it. Right? And if you want to change, you change like this. Come closer. So you can see a short gastric. So posterior gastric maybe. So I take with a short, slow burst. Okay. Go back. Go back. Go back. Okay. So come closer. Closer. Okay. Just pull that. This is the pancreas. Come closer. Yeah. Okay. That area, I think after splenectomy, the anatomy slightly changed. But we are managing at the moment. Vibhuti, can you just put this one? Suction. I need a little bit of suction, isn't it? So my area of interest is not clear. Vibhuti, can you do this movement? Yeah, excellent. Harmonic, please. That's hiatus as well. Okay. So I'm not sure whether it's spleen is in the different place. Okay. So come closer. Withdraw. Okay, we pull it up, pull down. I think, yeah, don't, ready, Allah never. I think she has a diaphragmatic hernia, is it? So it may be in a hiatus different. Okay, we will dissect this part. Can you just pull this one and see? It's okay. So there's one possibility is like either spleen is in the diaphragmatic hernia inside. That is one possibility. Just remember, because I didn't see the short gastrics much, so always think there's a possibility. You have to look for the spleen. Aha. Right, okay. Don't worry. Suction gun. Sakara. Swab එක ගත්තද? Maybe thoracic blood, but no, it was bleeding, isn't it? It's a bleeder, ne? So I think, yeah, suck. I think we did not panic at all. So the lesson is, because I think it's a short gastric vessel. Possibility is like it's somewhere there's another few more short gastrics. So, sakkaran. We'll wait till the gas goes up. Sakkaran epa vibhuti. So we'll go from below and see what's happening with the short gastrics. Gas pressure එක චුට්ටක් වැඩි කරන්න පුළුවන්ද අපිට 14 වලට? So I'm little struggling with the gas. Withdraw. Yeah, come below. Come from below. Yeah. Clean कर लगा? Clean it. Clean कर दें. So we are cleaning the camera. Sorry. Come forward. Yeah. No. Yeah. I think there's a little more short gastrics inside. So it looks like a bit of a diaphragmatic hernia, isn't it? So spleen may be inside. So when you try to check all the things in one patient, I think we have that patient today. Niroshan, thank you very much. You guys listening or sleeping? People ඇහෙනවද එහාට? Have they left? Of course. Maybe. Yeah. No, the thing is, you can see it. Yeah. It's a good suggestion, yes. Because I think I just have to release few parts. But I really doubt, Aravinda, can you see? It's going behind this fundus. I think I can go from below. Below. Yeah, I prefer to go below. Suction, please. Suction එක දාලා retract කරගන්න. So you can use the suction device as a retractor. Whenever I want, you can suck a little bit. It's okay. Lung in. හරි තමයි බ්ලඩ් එනවනේ. පොඩ්ඩක් ඉන්න විභූති මේ හරිය දෙන්න. පොඩ්ඩක් ඔකත් මට උඩින් සක් කරා. When I'm burning this, Vibhuti is bit of doing some suction there, so suck kara. Yeah, I think it's thorax. No, the thing is, there's an attachment there. It's not the... No, this is a different part. So, what I feel is it's a fundus. Fundus has gone into thorax separately, isn't it? So, yeah, okay. Lung in, lung in, lung in, okay. So what I am trying to do is separate the fundus from this is the diaphragmatic inferior surface. So this is the diaphragmatic inferior surface, right? Okay. So yeah, so there can be only one winner. It is the surgeon, Aravind, isn't it? You can't lose. Okay. So we will see whether there's any bleeding significant somewhere else. Just check bit of a bus. Yeah, suggestion as Aravinda mentioned, I could have put a sob. That is one option. But I felt, it's totally stuck there. That's why I proceeded we can dissect anteriorly and come to media side. That is come forward. Yeah. Okay. So we have little more dissection, isn't it? Okay. Some people dissect anteriorly and posteriorly, both in the, around the crus. You lift your hand up? Yeah, okay, fine. Yeah. Can you put your grasper below mine? Yeah, left crus, and I want Vibhuti to put and give me some good retraction. So he is doing fine. Thank you. Hari. So shall we now? Yeah, true. No, there's another inferior. Is it short gastric or inferior phrenic? Yeah. Yeah. Yeah, it is folded, Aravind. I think it's because of the splenectomy. Yeah, true. Can see. Okay, so few tissues to go. Can we take those from other side? One option is to take the attachments from side. You can lift it up. Yeah, thank you. Come forward, please. Yeah. So we are going to make the stomach tube soon. So we are going to make few staplers, few staplers. So I think Covidian kindly giving us some staplers, isn't it, Niroshan? Thank you very much. So right, okay. Part of the crust, am I going to take in part of crust or no, right? No death, you know. Yeah, that's the thing. Yeah. You can see the vessel, see the vessel here. So what you see here in between crust, this is the right crust, this is the left crust, this is the aorta. So when you are doing a dissection, please think those anatomical structures, appreciate those things, and unless you harm, they won't harm you. Okay, pull it down, we'll see whether dissection is complete. Tatiana. Yeah, so we are going to see from this side. Yeah. Yeah, okay. A little bit of blood. Yeah, I need to take those things out, isn't it? Yeah, lymph nodes should be come here, neither. So I will take it from here. Yeah, all yellow structure should come down. I mean, come toward the specimen. All yellow structures. Yeah, I think we are separated. Nothing. Any band holding? Okay, so fine, excellent. Hurry. We have to check posterior. Next step is, whether your posterior dissection is complete, because any strand will hold the structure without, it might not go up. So some people have a habit of putting a small sling and go from below upwards. So Aravinda, did you put that? I think I could remember. We put a sling. We take the sling up to the GOJ, isn't it? At that time, but I think now we have changed. Right. Okay. So quite a long stomach. Good. So then next step is whether can I see my pylorus? Withdraw. I think so. We'll see. Because when I lift it up, the this colon should not go up. So it is not so yet, isn't it? So that's what I'm trying to do now. I hope I'm not going to hit the gastro. You can see it's a sweeping movements. Right side. Are you all happy? Or any more? Yeah. Yeah. True, true. Yeah. Yeah, it is. It is. She is very scared. So aim is now pylorus should reach the hiatus. And you look at the transverse colon. Transverse colon should remain in lowest posture. So we achieved that. I think I'm quite okay. Any okay. So any dissection do we have to do below? මෙතන පොඩ්ඩක් කරන්න ඒ වගේ නේ. We have to do a little bit. Sorry? මේකද? Oh, I think it's මේක තමයි I think this is a gastroepiploic vessel නේද? You can see this is the gastroepiploic vessel, isn't it? වැඩි හාරන්න බයයිනේ. Telling me honestly, I don't want to. It's going to this one, eh? We'll leave it. I don't want to cut that. Honest. Yeah. Okay. So next step is making the you have two options of making the gastric tube. One is you can use the staplers laparoscopically. Second option is you can take a small mini laparotomy at the pylorus, level of the pylorus, and divide at neck and make it. Divide at neck and pull everything down and take the specimen out at the mini laparotomy and make the stomach tube outside, and it's an assisted one then. So the other one is pull everything from the neck. But the thing is you have a huge stomach in the neck. So shall we pull the NG tube up? අපි මේක හදමු නේද? මේක හදමු. ස්ටේප්ලස් තියෙනවා. දෙකක් විතර පෙන්නලා ගහලා. යා. ඊට පස්සේ අපි එකෙන් මේ කරමු නේ. ස්ටේප්ලස් දෙකක් තුනක් පහය කරලා. Yeah. So that is one option, isn't it? Right. Okay. So I have found the place. So that is the level of the incisura. I'm going to make the laparoscopic stapler. Okay. And staplers here. can we, we are going to use 15 port now because we need to 15 එක එහෙම නැත්නම් අපිට මේකෙන් දාන්න පුළුවන් port එක බාත වේද නෑ මේකෙන් පුළුවන් හරි මේකෙන් පුළුවන් yeah yeah so at the level of the incisura so කළු එකක් දෙනවද first one black stapler black ඔක් ගන්නකො ඔක් කඩන්න මිස් NG එක සාමාන්‍ය කොච්චරද දාන්න තියෙනවද NG එක බලමු yeah we come from NG tube so we are going to before firing the stapler please remember to pull the NG out you might otherwise definitely going to take the NG cut across the NG and there's a leak then after that try stapler එකේ black එකක් තියෙනවා they have brought තියෙනවා company එක ගෙනාවා company එක අහන්නකෝ so it's bit thicker first one you know I need bit thick one right then other one I'm quite okay for පොඩක් හොලවනවද NG tube එක නෑ පොඩක් අහන්නකෝ කම්පැනි ඒගොල්ලෝ කිව්වා තියනවා කියලා black එකක් ගේනවා කිව්වා black එකක් නැත්තම් we will be using the same thing කොච්චරද ගත්තා ඔය ගාන නැතිනේ නෑ ඔය ගාන නැතිනේ හා හොල්ලන්න බලන්න මෙතන හොල්ලන්න නෑ හෙල වෙන්නේ නෑනේ මෙතන විතරයි හෙල්ලෙන්නේ මෙතන හෙල්ලෙන්නේ ඕකේ හරි මෙහෙ හොල්ලන්න නෑනේ හො කොච්චර අදින්න නේ පොඩක් ඉන්නකෝ ඒක එතන බලාගෙන අදින්න හොලවන්න දැන් නෑ ඒක හෙලවෙන්නේ අර ඔට්ටද කොහෙද so one other step I wanted to mention if you think your hiatus is smaller when you pull up this thing please make your hiatus bigger right මේක ගහලා ඉවරලා අදින්න කලින් හරි you need to make this one hiatus is quite okay I am not going to make it bigger so මනතේ neck එක තා පොඩ්ඩකින් පටන් ගමු නේ we'll fire few staplers and show you හරිද අපිට 15 එක බාට මේකම හරවමුද ඔව් අපිට මේකෙන් පුළුවන් කැමරා එක මේකෙන් දාමු නේ so we are going to use the suprapubic plate for our advantage come on that's okay ලේඩ ඔන්න අම්මට සිරේක දිග haha can see we put a 15 port okay we go to 15 port and actually it should have come from left side but we use the same medium incision we might have to struggle a bit okay එන්න ඉස්සරහට හලන්න එපා හෝල්ඩ් කරන්න එපා වැඩිය so you pull from the other one lift කරන්න fundus එක lift කරන්න from your one තාපඩක් so මට බවල් ගාස්ප් එකක්ද so නිබුති මට පොඩ්ඩක් අතාරින්. මට ඔය ෆොට් එකද? grasp එක? Yeah. I prefer short graspers. So this is what we do in sleeve gastrectomy. Might have to go for proper port, I think. Yeah. Don't completely cut across the stomach. Huh? Those are the things which can happen. I want to get the proper lesser curve. In the meantime, I have to go and check where the left gastric, right gastric is okay. So, and also whether, is it too much? Is it too much? Okay. So it's too much. Make a release. Yeah. Okay. Stomach is a bit twisted. That is okay. Karine? Karine is
anterior wall looking at
Karine? Karine? මේක ටිකයි යන්නේ. ගොඩක් යන්නේ. මේ ටික තියෙනවා? Yeah, that should be fine. This is the starting point. We may not put a big stapler. හරිද? මොකද වදින්නේ මේ එතෙන්ට එනකම් විතරයි. It's a very small part it's going to go. හරිද? හරි නේද? So we check, recheck because there's no coming back once you fire the stapler. It's better to recheck everything. Right, sorry. Only thing we were trying to save a port, but that's quite okay. I'm going to fire this. Yeah. No, I actually put it from the umbilical port, which I already put it before, right? So, yeah, that is why this thing. Sure. Very true. No, very true. But I totally agree with you because I was trying to save a bit of another port. So that's what I should have. I totally agree with you. මට දෙන්න මේ suction එක. So I'm going to suck some this. Okay. Come forward. Actually, we did the first one firing. So other firings, I think. Oh well, this is a tri-stapler. This is very quite safe stapler. Gas නැති වෙනවනේ අපේ. Gas pressures are we lose මේක හරියට. No, I think it's because we this gas pressure. හරි. Then මේවා purple. I think we will be firing few staplers here and then we are going to pull the specimen up. So that is the plan. Okay, you can see this is okay. This is the just beginning. You know, it has a bit of a strength, this one. So then Vibhuti. Yeah. Okay. Pudding and apple. Can we push more, you think? I think we are okay. Yeah. Okay, we are okay. Arine? Yeah, fine. Yeah. Don't cut across the splenic vessels, huh? Because you might push the stapler and your edge may be in the splenic vessel, right? Those are the mistakes which can happen. Okay, so it's not very nice tube though, because I can angle it slightly with the next one. තව එකක් දෙන්න. ඒ જાතියෙම. Yeah. Purple. So as we put tri-stapler, you don't need to strengthen this one. You know, look at, සාමාන්‍යයෙන් staplers ගැවුවම generally accepted at least to edges. Why do you want to strengthen the edges is sometimes because when you pull it out, අර edge එක can get apart slightly. You can turn the way you want, okay? හරිද? මම පොඩ්ඩක් මේකේ අර edge එකටම යන්නේ නැහැ. Because I want to පොඩ්ඩක් මේ බලන්න edge okay නේද? Sure නේ edge එකට ඇවිල්ලා නැහැ නේ? Yeah, okay. ඇඟ හීතල වෙන එකක් නේද ඒක? Okay. So rest we will assess now whether you can completely take this out. I mean, you can අන්තිම staplers දෙක fire කරන්නේ නැහැ සාමාන්‍යයෙන්. You just leave it because you can, yeah. So I think we will pull from the neck and do the rest, right? තව පොඩ්ඩක් මේක ටිකක් ලොකුයි. I should have තව එකක් දාමුද? නෑ පොඩ්ඩක් බලමු. එකක් ගහන්න ඕනද කියන එක තමයි බලන්න ඕන. Because you might හරිද? ටිකක් තියෙනවා. මේ මෙතනින් තමයි. I should have gone here rather than this. අපි එකක් ගහලා යන්නේ. So then අතරම අපි උඩ බැලුවම yeah. So this one we will put across like this. මොකද බය තියෙන්නේ හරියටම ඉසෝෆැගස් එක දෙකට කපනවා සමහර අය ස්ටේප්ලර් එකේ. It has happened. And so mistakes do happen always. So හරි. හතරක් නේද ඒතකොට? දැන් අපි කීයක් ෆයර් කරාද දැනට? මේ හතර. Okay. ස්ටේප්ලර්ස් අපි හතරක් ෆයර් කරලා තියෙනවා. So මගේ ටියුබ් එක දැන් like we don't go to the edge because we want to shape up. හරිනේ? හරියක් යනවද? නෑ නේ ඔයිට වඩා ගියොත් yeah. Okay. හරි නේද? Okay. So I think we are quite done. ඔයිට වඩා කරොත් ගැලවිලා නේද? So I think if you do more than this, it can well, so it's you can pull it out, pull it up, so you can have a tube, nice tube. So from the neck we will be pulling up, and then dividing this part we can straighten everything. So I don't think we need to put a drain. We generally don't put a drain here. Do you want any drains or anything? Niroshan, you want? Is Niroshan sleeping? Putting me in difficult position, I think he must be enjoying some cool something. Okay. So I think this is what the generally outcome is. So okay. Right. Shall we suck everything in this area? So because earlier that was bleeding, I really don't want to, it's settled. So Aravind, are you happy with this? Yeah. Okay. No drains. So we are going to start the neck. So again rechecking. Pylorus going into neck. Sorry, pylorus going into the hiatus. So and this is remaining. So that is the last lesson. That's all. Okay, done. Oh, hurry, we'll remove it. So okay guys, so we are going to switch off from the laparoscopy, and Vibhuti is going to start the neck, and I'm going to close up this thing. So we are going to take the Nathanson retractor. We are going to take, please take ports under direct vision. That is the lesson, because it can bleed. If you get a complication in the UK, if you don't document that you have taken the ports under direct vision, you are sued. So but gas off please. Yeah, thank you very much. Thank you, miss.
Thank you, Chaturanga. I think we had a wonderful live operative demonstration.
Gas off please. Yeah.
We had two wonderful surgeons who performed surgeries.
No, magi migala. It's
Exactly.
can ask for associate membership. So once they qualify, they can become full members. So they have to pay a membership fee of 5,000. Now already Udvik is getting his membership by paying 15,000 to become a full member. So I got the application forms in the, if somebody is interested, please get the, you don't need to pay it now, you can even pay to the college of surgeons through bank account. So enrolling these sort of activities generally becomes very surgeon. So do you have any questions regarding today events or anything to know about esophageal cancer management and surgery, anything? If not, I would like to, because now we are going to do the anastomosis, particularly in the specimen through the neck. So it's, neck anastomosis, you all know, if somebody is interested in it, but it can be a anastomosis. So if nothing is okay, I'd like to conclude this session. All right, so we are going to have another little session after this major session. It's again extension of the academic, right? They are only some unsung heroes become heroes. So including the grandma. So everybody is welcome there. In addition to that, I want to thank you all the sponsors of the event, Electronics, and all the others who supported, and also the audio show team who really gave us good time. Otherwise, we wouldn't have enjoyed this comfort here. So I would like to conclude the event by thanking you all for participating. Thank you.